Hello, can you hear me?
Good morning there, Stopdown. Yes, I hear you.
Nicholas, good morning. How are you?
Thanks, good. Great to
I
see
think same here. So I think we should be starting now. I'm waiting for somebody to tell me we start.
Yeah, I think we can start already.
Yeah. Okay. Well, a very good morning and warm welcome to all of you to the day 2 of the 5th International Conference on Integrated Control of Tuberculosis in Central Asia. A brief introduction about myself. My name is Stopdan Kalon. I'm the Regional TB Advisor for the ETICA project in Central Asia. I'm going to do a quick recap of yesterday's sessions, and then we give the floor for the presenters to begin the day 2. So to give you an overview of yesterday's presentations, we had a wonderful beginning to the conference yesterday. To begin with, we had a very informative and excellent presentations in the plenary, which gave us the global and the regional context, and reminding us that TB still remains such a big challenge. And then we talked about, while there has been a gradual decline in TB globally, but the overall burden is still massive, and it still remains the #1 killer in the world. However, drug-resistant tuberculosis continues to be alarming, and particularly in the Central Asian region and the Eastern European and the Central Asian region, the most of the high-burden countries come in this region. The other thing that came up in the presentation yesterday was it was highlighted that TB still remains highly underfunded. There's a huge funding gap there remains in TB, and which has been further aggravated because of the COVID pandemic. And also, as the most countries are now expected to step up the level of domestic funding, we see that most of this initiative that has happened is still mainly happen in the BRICS countries. So meaning that other countries, there's a lot for other countries to do in terms of stepping up the domestic funding for TB. And then with regards to the progress on the UN high-level meeting targets, we are far from reaching the targets, and there's still a lot to be done. While there's some work is being done, but it's not enough, and there's a lot of work to be done ahead. And then we had, in the last 1.5 years, been confronted with an unprecedented scale of public health catastrophe in the shape of the COVID pandemic, which has disrupted every aspect of our life. Healthcare services have been disrupted, and TB among them have been one of the most affected aspects of health services around the world. And we've seen that huge losses the countries had to bear losses over the gains made on TB progress. And it will take a lot of efforts to catch up with those losses. Sorry. And then Sevim highlighted the great support that the USAID provides globally and particularly in the region. And through the Global TB Accelerator to end TB, to leverage additional resources, whereby helping UN target treating 400 million people with TB by the year 2022. And then USAID's, we heard about the USAID's recovery support for TB programs in the most acutely affected countries, where the TB programs have been acutely affected by COVID globally. And then we heard about a lot of ideas how to capitalize on the opportunities arising due to the COVID challenges. And then we heard about from the host countries program manager, Professor Parpaiva, about the she gave a very nice historical overview of how the country has been developing and rolling out its strategies and roadmap to eliminate tuberculosis. She very nicely highlighted the fact that TB services need to be patient-centered, holistic, and there needs to be a multi-sectoral approach to address TB comprehensively. And the country continues to be at the forefront of combating TB through innovations and pioneering work. And yes, indeed, with her charismatic and capable leadership, the country is moving forward. Then we saw some wonderful presentation about the significance and the role and the significance of the civil society organizations by Paul and Yulia. They spoke about how we should be tapping the potential of engaging the civil society organizations in order to have equitable, people-centered, inclusive, and effective programming for TB services, and then and to strengthen all aspects of TB care comprehensively. It not only adds quality, but also ensures a genuine people-centered care in TB programs. They highlighted the fact that there is a need for serious and genuine engagement of the community and the civil society. There is also the message they highlighted. There's a need to create funding for the civil societies, to also allocate adequate funding for the civil societies to do meaningful work. With regards to the diagnostics, we saw that the national, while there are a lot of developments happening in the field of TB diagnostics, as we all know, a lot of promising, exciting tests coming up. The national reference labs of the regions have been they have continued to grow in capacity, with great support coming from the Gauteng supranational lab for the region. While conventional testing diagnostic methods are being strengthened, new game-changing tests like the sequencing tests, which shows a great promise to transform TB diagnostics in the near future, are being starting to be implemented in the region, and we'll see these coming to its full potential in the near future. We also see in the laboratory, in the field of diagnostics, pioneering work related to the DSTs for the new drugs also happening. So that's very useful, particularly with the context of the rollout of the new drugs and the shorter regimens. And then we heard from the representatives of the TB programs in the region, the progress and they have achieved, and the challenges they're confronted with, and how they are coping up and finding ways forward. As we all know, the countries of the region are highly burdened with TB and drug-resistant TB, and also legacy and the remnants of the obsolete Soviet-era policies and practices. The NTPs of the region continue to make great efforts to adopt modern methods and policies. We see big progress being made in the implementation of the shorter regimens like MSTR, with support of WHO and partners like USAID on the ground. We see in Kazakhstan, Tajikistan, Uzbekistan, the MSTR is being implemented. At the same time, other shorter regimens like the BPAL, TB Practical, and NTB in the different countries are also happening. And also initiatives for preventive TB treatment is also starting to happen, although it's early days and much needs to be done in that regard. And then, yeah, there was again, it's noteworthy to see how the region has actually responded to the COVID pandemic. The programs have shown great resilience and adapted to prevent further losses due to COVID. And we saw several innovations coming out in the programs to cope up, which has actually given rise to solutions for the going forwards. Particularly the use of community volunteers, adapting TB services, improved infection control, bidirectional testing of TB and COVID, use of digital technologies not only for patient support, but also for carrying out activities like consiliums conducted online, trainings being conducted to healthcare workers. So that's something really great, and we need to adopt, embrace it going forward. The technology, use of technology. And also the NTPs are in the process of developing their national strategic plans and developing, strengthening their roadmaps to achieve the WHO, NTB, and the UN high-level meeting targets. And it was also interesting to hear about the technologies like computer-aided diagnosis and artificial intelligence. So this is something really great. We know that some of the countries are already going to be initiating pilot initiatives for these interventions. So all these informations, discussions yesterday, it very nicely sets the stage for the day 2, and I hope you will have a day 2 which is engaging and as informative as yesterday. And without taking more time, I wish you a great day ahead, and over to our session moderators. Thank you.
Thank you, dear Stopdown. Good morning, dear colleagues. Здравствуйте, доброе утро, коллеги.
Good morning, colleagues. Good morning. My name is Nicholas Nasidze, and I have the honor to moderate today's session, today's plenary session. And first off, I would like to express my thanks to the organizers of this very conference, which is really important and very interesting. Just like Stopdown mentioned earlier, the first day was very, very useful, very informative, and I hope hopefully the second day and all the other remaining days will be as successful as the first day. Now, as for today's plenary session, together with me, there will be my colleague moderating the event, Saigas. You'll see her. Good morning, Rita. I am a counselor to the national TB program in Uzbekistan. This is on the STAR program. I'm sure you know this. You all may have heard about this program. It's a technical analytical resource support. Brita is as a counselor in Kazakhstan of the national TB program. She is a specialist on issues related to managing the quality of anti-TB drug, and she has experience working in GTF program. Rita, maybe you would like to say some welcome remarks. Maybe you would like to welcome. Good morning, all the participants of the 5th conference, and I hope that we'll have a very interesting, very productive day, and we'll hear a lot of good and interesting presentations, and there will be a lot of discussions and questions. Thank you, Rita. So literally in 2 words, I would like to talk about the session itself. So the issue is really interesting. It's a really extensive session. During this plenary session, we'll be speaking about creating favorable conditions for sustainable fight against TB, and this is a very wide-ranging concept. So we'll be talking about the financing issues and about the providing of the services, about involving the communities, local communities. So everything that helps us to bring our knowledge to our drugs to our patients, our population in the way that it's really acceptable, it's really comfortable for our patients, for our population. And I would like to now, in 2 words, say that we'll have 4 presentations this morning during this first session, plenary session, and the time allocated for each presentation that we're allocating to our speakers is 15 minutes. And I ask all presenters to please stick to this 15-minute limit so that we have enough time, so that we have time for a Q&A session. Additionally, if during the presentations, if somebody will have questions, you may submit them in Q&A session in writing and or in the chat window in the Zoom platform, and our presenters will be answering your questions. Or if we have some time remaining, you can show raise hand icon and ask your question, and our presenters will answer them. Now I would like to say a couple more words about our technical support team. Thank you very much to them for administering our event, and we want to make sure that all the presenters have their access to their presentations, so that they're able to prepare, open their presentations, and share screens when they are presenting their presentations. So we're starting out today's day with the presentation from Kazakhstan, from Kyrgyzstan, sorry, and it's really pleasing. It's my really great pleasure to present to you Rahat Cholru. Rahat, she's my colleague, whom I've been working with. Have a great history of joint collaboration in Kyrgyzstan. I'm really happy for this opportunity to welcome Rahat. She's also participating in over the past 10 years in all the programs that are helping or promoting improvement and reforming the healthcare systems in the country, in the Republic of Kyrgyzstan. And then at present time, she is the deputy director of the USAID project and TB in Kyrgyzstan. And I give floor to Ms. Rahat, and she may start her presentation. Rahat, Ms. Rahat, you have the floor, ma'am. Good morning, Nicholas. Can you hear me? Can you see me? Can you hear me? Yes, we can hear you. Thank you very much. I will now try to bring up my presentation, share my presentation with you. Hopefully, you can see my presentation now. Yes, we can see your presentation. Yes. If you switch to slideshow, yes, we can see it now. Excellent. Thank you, Rahat. Thank you. You have the floor. Good morning, dear colleagues. Good morning, Nicholas, Rita, and everyone. Thank you all very much. First off, I would like to thank participants and organizers of the 5th International Conference on Integrated Control, Integrated TB Control in Central Asia, for the opportunity to share with the Kyrgyz Republic experience. It's a really great honor for me to speak about the results in Kyrgyzstan at such a prestigious conference and get feedback from my colleagues from our region. I will try to stick within the time frame allocated to me. Can you hear me, Nicholas? Rita, can everyone hear me? Yes, Rahat, we can hear you. Yeah, yes, we can hear you very well. Thank you. And we can both see a presentation and we can hear you. Thank you. Excellent. Then I'll continue. So here we have the structure of my presentation for this morning. Let me start with so my presentation is about reforms in the TB system in the Republic of Kyrgyzstan. And so I will try to stick to here we have the structure of my presentation. I will try to stick to the time allocated for me. So I'll start with the fact that I'll give a background and characteristics of our country. As was already mentioned yesterday, our country, Nicholas also mentioned about this. Uzbekistan is among the countries with a high burden of DRTB on annual basis. In our country, a quarter of patients are with the DR patients. And unconditional this presents a huge challenge and a huge challenge for the system of healthcare in the Republic of Uzbekistan.
Diagnosis and treatment of patients when approaching health facilities. And as you can see, our country still has issues with a low coverage of bacteriological testing, and the country is still trying to reach the WHO recommended targets for treatment success. And as you can see today, these are the results for treatment of DSTB, and we are still below the targets. As for epidemiological characteristics, along with poor coordination of TB care at various levels, low capacity and motivation of primary healthcare personnel to providing TB services, inadequate human resources at different levels of healthcare services, and poor access to laboratory services. So all these factors resulted in low effectiveness of healthcare system in our country. And definitely the issue of drug resistance to be added necessitated further commitments and responsibilities of our health system. And I would like to highlight that before 2018, so before the reforms started in our country, so most of the state financing of TB care had been channeled to hospital treatment, but at the same time, the facilities did not receive the whole range of supplies to provide TB care for the population. So their primary objective was to provide hospital services, and actually unjustified lengthy admissions were practiced, although back then the country adopted the protocols for, say, for expanded outpatient treatment and so on. But at the same time, the infrastructure of TB hospitals remained unsatisfactory in most cases and failed to provide safe hospital stays. And overall, all these factors became the basis and the rationale for the reforms in TB care system in our country. Although the reforms were planned to cover all the key functions of the healthcare system. So starting with changes in the care delivery patterns. So the relevant financing was supposed to be provided for the services, and the resources and systems had to be provided to ensure effective operations as well as effective management. So the overall set of measures was planned to improve the TB care system in our country by our government. So in 2017, and Nicholas is well aware of this document, so the government approved the action plan, so we call it a roadmap to optimize TB care system. In general, the document describes the key areas for reforms in our country. So the reform aims were envisaging establishing the patient-oriented model of TB care in Kyrgyz Republic within 10 years. So the period was before 2026, and I apologize. So we're having some issues. I don't know, someone is writing to me. Either they can see you or can hear you. The technical team, please take measures if the rest of the participants can check, please, with the rest of the participants if they can see the presentation, because I can hear you and I can see your presentation well. But someone is saying your camera is off, but no. We can see you and hear you well, the people are saying. Maybe you are having some technical issues. Please approach the technical team. I guess that was the message from the host. Well, Arhat, I'm sorry for interrupting you because I repeatedly received that message. Please continue. Can you hear me now? Yes, yes, so we can see you, we can hear you. But I received that message about that problem, and so I apologize. Okay. So the goal of the reform was to set up the patient-oriented model of TB care in our country so it could provide relevant services for our population, relevant high-quality services. And excuse me, stop them. Could you please switch off your mic because I can hear myself, the interpreter speaking.
Oh, yeah. Yeah. I mean, we were not able to hear each other. No, he was not able to hear me actually. Okay, so I called because my wife is. I'm in a conference right now. I will be all day, and so instead of me, my wife will come and.
Значит, основными направлениями реформ.
So the main areas of reforms were to expand outpatient treatment, improve quality of TB services at outpatient level, optimization and restructuring of TB hospitals to ensure effective and high quality TB services at these facilities, and also to improve TB laboratory diagnostics to ensure relevant testing techniques at all levels of healthcare. The roadmap timeline was split into 3 stages. And so with regards to the program implemented before and its future stages, but I would like to draw your attention to the fact as shown on this chart. The goal was, as estimated, as a result of optimization, the country was supposed to get savings to be channeled to the system functions that needed to be enhanced and that needed further financial support. So the roadmap outlines the key strategic areas and objectives and the primary healthcare level to be hospitals and to be laboratories. So as for TB labs, later on, I will give you more detail when I discuss the implementation status of this roadmap. And I would like to draw your attention to the conditions coordinated among all the stakeholders when signing the roadmap. And a key precondition I would like to highlight for you is the consensus, the agreement saying that the savings as a result of optimization could be channeled exclusively to improve the quality of TB care. And so far, in principle, this precondition and others are being implemented, and we do hope it will be implemented till the end of the roadmap implementation period. To ensure effective coordination and management of TB care, the Ministry of Health decided to fundamentally reconsider the role of provincial TB control centers, which before 2017 had operated as TB hospitals. And so they provided hospital care, and they were funded per case treated. And these facilities, provincial TB control centers, they were not functional. They were not financially ready to perform the functions mandated to them to coordinate TB care. And in 2017 to 2021, the range of activities was implemented almost in all provincial TB centers, where they revised the staffing schedule, job descriptions, structure, and they developed the functions for coordination of management. And an important element to change the role of provincial TB centers was the developed financing methods. So they added per capita standards, and provincial TB centers could know how much they could generate as a result of the capitation introduction. And starting 2020, dear colleagues, all TB centers at the provincial level have been receiving this amount of financing to improve their coordination and to ensure more effective performance. And the chart on the left is showing the hospitalization to be hospitals. And as you can see, the hospitalization rates are going down, especially the highest level of the downward trend were reported in 2019. And actually on the right, you can see the number of hospital beds. And I guess now you can see that here the reduction is not that intense. And one of the causes is the willingness of healthcare facilities to continue as before, so to preserve their independence. And as you understand, for that they require more beds. And actually in this very period, 2017 to 2020, ineffective hospitals were repurposed for something else, for other needs of the healthcare system. And there were interventions to ensure optimization, restructuring, reorganization, and definitely those activities were in progress. But given the situation last year, of course, some adjustments will have to be made, and the plan will be implemented by the Ministry of Health. So as for primary health care, the main objectives, strategic areas identified in the roadmap so far are implemented quite well. And the breakthrough is that the country reached the consensus in terms of TB case management, and the model was developed. We call it TB case management model. And the focus is switched from receiving TB services from TB doctors to receiving TB services from GPs, general or family doctors. And for that, we had to expand the functions of primary healthcare professionals, family doctors, and tools were developed so the functions and objectives could be implemented by family doctors. And an important point here is that the payment system was developed to provide incentives for primary healthcare personnel so they could cope with their expanded functions and tasks. And this is paid at the same time when the successful TB treatment is completed. And I guess more detail on that will be presented on day 3 at a relevant session on TB financing, and the public will make a presentation on that. So the current approach now is implemented in 3 provinces, and starting September 2021, this approach is extended to 2 new provinces, and this demonstrates a high level of commitment of the government, the ministry, to enhance primary health care. Here you can see the approach to case management, and please pay attention. This approach is broader. So there is a broader approach to patient management at the PHC level. So it's broader than just providing TB drugs and directly observed treatment at the outpatient level. So this approach also includes psychological care, social support of patients during treatment, before the treatment is completed. And much attention is given to treatment adherence. So, as part of case management, a great role is played by the arrangements of the controlled treatment of TB. And the key principle here to organize the controlled treatment is patient-oriented or patient-centered treatment. So various options were suggested, like engaging social assistance, video-controlled treatment, and the approaches should take into account the needs of the patient. Currently, the Ministry of Health is active in developing approaches aimed at active TB case detection at health facilities. And here, I would like to draw your attention to the fact that in our country, some 24% of patients annually notified in our country is detected in general hospitals, so diagnosed in general hospitals. But unfortunately, given the situation, we have very low level of my health professionals, and the active case detection approach is being adapted and introduced in this sector of the healthcare system in our country. So in parallel, we are developing the active case detection approaches among the key groups of the population. So based on the results, like how they will be pilot tested, so relevant decisions will be made for how the country can adopt these approaches and implement them further. As for tracing TB contacts, here our country engages various agencies like SAS, Sanitary Epidemiological Surveillance Agency, Primary Health Care, and TB Service. And now there is reconsideration of functions of each and every agency, and without relevant financing, without providing relevant personnel and resources. This area might remain on paper, just formal, and for that, pilot testing is underway for the expanded model that has not only the broader functions and algorithms for interaction among all those services, but also the issues for how we can ensure adequate financing of this area and how personnel should be provided. So the TB contact tracing could be well established. So as for health financing reform, so I guess I will not take much of your time. On the 20th of September, more details will be provided, but I would like to say that the financing reform is a driver for the whole set of TB care reforms. And the key objective now is to shape appropriate incentives to improve TB care in our country, to improve access and coverage with laboratory testing. Our country has developed and introduced almost in all areas the transportation system.
We accepted the model of transportation when the objective of transportation is given to outsourcing to the transport company, and this approach showed sufficiency. So in pilot format, they were that they used to plan the expenses and payment for the transportation in our country. Rahar, time, please. Yeah, it's about 2 minutes. On this slide, I would like to draw your attention to how this breakthrough has happened for key diagnostic methods. In relation to medical information systems, we will have a separate presentation. And again, big attention is paid to the development and introduction of information systems. And this allows reforms implemented in the tuberculosis aid to be more efficient and ensure efficient coordination. As far as the rest of the plans, as you probably understand, our country is in the middle. 2021 is the medium of the implementation of the roadmap. There are a lot of plans and tasks that need to be implemented, both on optimization, that will be continued, both on introduction of function approaches for treatment and primary medical sanitation help. So all of those activities will be continued, discussed, and piloted. With this, I will finalize my presentation and thank you for your attention. Thank you very much, Rahat. Thank you for presenting all these key aspects, as you have correctly mentioned, and I know about it a lot, about how it happened, and probably it was not easy to do. And now I would like to give the floor to Rigi, who will present the next speaker, please. Hello, everyone. The next presentation will be made by Mr. Lilian Karalan, who is Executive Director of Center of Policy and Research in the area of healthcare. This is an NGO located in the Republic of Moldova, but it's an organization with a big experience of introduction of healthcare programs with different diverse coverage of healthcare systems, infectious and non-infectious diseases. Lilian has a big experience in leading healthcare programs. It's about 17 years of her leadership work. Currently, she is a leader of the grant of TB-RAP, which is a regional grant, which implements programs in improving the measures of controlling TB in that region. The presentation will be focused on the role of the organization of the civil society under the support focused on people. And the special focus of this presentation is a standardized approach of supporting services at the level of communities in order to improve the results of treatment of the TB in the Vetsa region. Therefore, I think that we'll have very interesting discussions, and therefore I would like to invite all participants to listen and be active and ask questions. Liliana, please. Thank you, Rita. Could you confirm that you can see my presentation now? Yes, we can hear you and can see your presentation. And please expand your screen. Just 1 second. Is it better now? Definitely. Thank you. Once again, go back to the format you had before that. Somehow technically it does not allow me to do that. When I'm trying to expand it, it disappears. What about now? It is expanded now. Is all good? Go back with. It doesn't let me do that. Could someone launch the presentation for me, please? Technical team. Could you help us? Perhaps you close your presentation and I'll try to share it myself.
Сейчас хорошо видно для всех.
Is it better now? Can everyone see the expanded format now? Yes, we can see it good. Thank you, Rita. Sorry for this technical problems. It's too early in Moldova yet. Dear colleagues, good day everyone. Let me welcome you on behalf of the team of Center for Policy and Research of Healthcare and TB-RAP program team. Majority of you know TB-RAP programs, TB-RAP 1 and TB-RAP 2, since you're representatives of the countries who participate in these programs and are partners on their implementation. The first TB-RAP in 2016 and 18 was focused on resolving one common problem of our countries in the region, including Central Asian countries, which is outdated model of providing anti-TB aid, which is focused on full hospitalization and lengthy stay at the hospital that facilitated to development of high-time treatment of TB and ineffective use of resources. TB-RAP was focused on ensuring political commitment to transit to the new model of anti-TB aid, which is focused on the needs of people, and development of the conceptual model for this aid for DECA countries, and a set of tools
to assess legal framework, forecasting, and planning of the human resources and others. In 2019, TB-REP has expanded the focus of the previous program and focused on improvement of the quality of anti-TB aid, focused on the needs of the people through the high involvement of the TB community and civil society and development of the integrated approaches, which are able to satisfy the needs of all key and vulnerable groups. With the change of paradigm of combating tuberculosis and active transition of our countries from vertical models to new, more coordinated models of aid, we can see the growth of the demand for the services for rather vulnerable and other groups of population, which are focused on the sustainable growth. Unfortunately, the biggest difficulty in providing integrated services focused on people in our countries, there is a lack of clear definition of the services. Package of services, minimum quality standards provided, and the estimation of the costs that would allow our countries to develop those services which are provided under diverse projects and to develop sustainable mechanisms of social order for better quality of involvement of the civil society and communities and handover after the donors by the government. In response to these challenges and to provide a conceptual model of aid that has been developed in 2019 under the second TB-REP, European Bureau of the WHO and the Center for Policy and European Coalition on TB developed standardized package of support services at the level of community to improve the prevention and treatment of tuberculosis package. The document provides the developers and the representatives of these communities tools to identify the costs of services in order to implement them and further introduce in the base package at the local or national level. The standard approach describes non-medical services during the entire continuum of the anti-TB aid, starting from increasing awareness and mobilization of community and ending with the social support and rehabilitation after the treatment is over. The services are organized by 4 fields of prevention, detection, treatment, and care and support. And in total, we have included in the package 12 services. In addition to the above mentioned, the package describes also services on consulting persons with confirmed risk to TB, non-clinical case management, accompanying the treatment under supervision, further treatment and surveillance, psychological consultation and support, comprehensive case management, material support, and others. Additionally, the package describes the services with special groups and in special conditions. The special focus is paid to the services for people who are convicted or those who do not have the place of living. And the special focus is given to the family approach of treatment of TB with children and times of emergency in healthcare, like COVID-19 pandemic. For each included in the standardized package service, we provide standardized detailed description, which includes goals and tasks of the target group and services provided with a focus on its planning, continuity, place of provision, and necessary resources, assessment and reporting with specific indicators of quality and quantity, and documentation on case management, and algorithm of services provision. Rita, could you go through the next 4 slides quickly? I will not stop them because the presentations will be provided to all the participants and you will be able to learn it in detail. But these slides provide the description from the first package of service, which is increasing awareness of the community mobilization of the local community. On this slide, I would like to tell you more, since it's a very important component of the document, which is a methodology of cost estimation included in the package of services, which is to serve as a practical instrument to forecast costs, to provide support services to the stakeholders at the national level, such as Ministry of Health, National TB Program, and civil society institutions. The methodology describes the components, calculations, and their volumes, sources of information, and principles of estimation, and has step-by-step instructions to identify the cost. And the most important methodology, we have the tool to estimate the cost, and the next slide provides some abstracts of that. Standardized package of methodology of estimation is a framework document so that countries can easily adapt for specific needs in the country context and national standards of services according to the normative legal framework and procedures. Additional to the internal expert assessment, the package has, and I will use this forum, and I would like to thank all Central Asian countries with Professor Perfieva, who is the chairperson for this conference, for invaluable recommendations to improve this document. And what's important that in parallel with the development of this publication, which takes quite a long time due to requirements, currently 9 countries of VETSA, who are the participants of the TB-RAP program, including 3 countries from Central Asia, Kazakhstan, Tajikistan, Kyrgyzstan, have taken this document for introduction and adaptation. At the end of my presentation, I would like to mention that we all have the general understanding that for improving the results of treatment and prevention of the TB, we need integrated approaches focused on the needs of people, which can satisfy all the needs of key and vulnerable groups. And for this, we need all actors with their specific knowledge and skills. As we all say, nobody wants to play chess with only a queen at hand. Therefore, the role that could be played by civil society in this fight is key. And therefore, our joint task is to make that those services that people expect, that could help us improve the Thank you. Thank you, Madame Kraulan. And I think this presentation and others will be causing a lot of questions in this conference and other periods, because this presentation highlights important thing that, and we all understand it, that we need additional partners like as a civil society, because we quite understand that their involvement is paramount, and we need standardized approach and identify what kind of services they can provide. And therefore, I realized that this document provides for entire list of services on all components of the TV service, as well as the composition of those services, and what's most important, this estimation of budget, so that we can further advocate in the country to be implemented. And definitely this package will help to have the framework base so that the services are of quality and efficient and rational. Therefore, I think that there will be a lot of questions. So your and your colleagues' views who participate in creation of document will be very valuable. But this will be in the session of questions and answers. So thanks again for your presentation.
It was my pleasure. Our next speaker is Mrs. Smith. She represents Partnership Stop TB, and the matters that will be covered by this presentation are covering protection of human rights, introduction of the society, gender equality, like full society approach in order to improve the results in controlling TB. Madam Smith is representing a department, and the name of that department is the Society Human Rights under the Stop TB. Before that, she was the part of team of Global Fund and also Partnership for Health in Boston. So unfortunately, she will not participate live, and it's covered also with her voice. And even if she's not with us, we kindly ask everyone to listen to the presentation and then to prepare your questions. Thank you. Technical team, please. We don't hear the voice. We kindly ask a technical group to help us.
Good afternoon. My name is Kiva, and I work on the Country and Community Support for Impact team in the Stop TB partnership, specifically on community rights and gender. Unfortunately, I cannot be with you, but I know that my colleague, Dr. Andrei Masniaga, is with you, and I look forward to meeting you in person soon. I will divide my talk today into 4. I will briefly talk about why community, human rights, and gender matter in TB. I will pinpoint and highlight the strategic importance of CRG as outlined in multiple strategic blueprints and documents and plans to end tuberculosis. Thirdly, I will explain what and how the Stop TB partnership is supporting countries and communities to operationalize the principles and objectives of community rights and gender. And lastly, I will speak to some of the work that I'm aware about in your region, specifically from Tajikistan, Kazakhstan, and Kyrgyzstan, and how the Stop TB partnership will further support CRG advancements in these countries. So, to the first point about why CRG matters and how CRG interventions can contribute to ending tuberculosis. Well, the fact remains, as we all know, that every year the health system is missing millions of people affected by tuberculosis, especially among key and vulnerable populations. And this is because of barriers to health services, human rights violations, stigma, and a lack of access to support services, all of which is now being exacerbated by COVID-19. So in other words, millions of people affected by TB are being missed year in, year out by the health system, and not just because of gaps in the health system, but also due to the environment within which people are trying to access services. So to reach these missing millions, we need to transform the TB response, as you are doing in your region, from a response that is passive to a response that is proactive, one that assesses the environment through which the most vulnerable people are trying to access services, and to address these challenges and barriers in a people-centered manner that meets the holistic needs of people affected by TB. In other words, we need a response that puts communities and their needs at the center of the C, a response that is founded and driven by rights and people's rights to health, right to social support, right to education, and other rights. This is the R. And we also need one that acknowledges and is responsive to the needs of all genders, the G. So a CRG approach to tuberculosis. So at a global and strategic level, the importance of CRG is recognized. In the N2B strategy, it acknowledges the importance of strong coalitions with civil society and community organizations, as well as the protection and promotion of human rights. In the Global Plan to End Tuberculosis, it establishes that CRG is a key requirement to end tuberculosis. In the UN Political Declaration, world leaders have also affirmed their commitment to ending TB using a CRG approach. And the current Global Fund strategy and mechanism reaffirms the importance of CRG, but also, and more importantly maybe, makes resources available to countries to advance human rights and gender equality to meet the needs of key and vulnerable populations. However, today we know that we are not on track to meet the targets to end TB by 2030. And we know this from the UN Secretary General's report and the Community's Deadly Divide report, both of which acknowledge the lag and call for the transformation of the response to be rights-based, equitable, stigma-free, with communities at the center. To support the operationalization of these CRG commitments into action and investments, the Stop TB partnership, in collaboration with partners, developed over time and based on country experiences a relatively comprehensive package of support for countries. Namely, number one, we developed a CRG framework which consists of different CRG intervention areas to guide a comprehensive CRG approach to TB. Number two, we developed CRG tools and guidance which support CRG implementers. Number three, we developed CRG investment packages, which provides guidance to programs on CRG investments for the NSP and for Global Fund funding requests, for example. We also have a grant mechanism called the Challenge Facility for Civil Society, which is for community and civil society to test and to implement CRG innovations. And we also have a technical assistance program, which is led by CRG experts from across the globe and which links to Global Fund and USAID investments. So in terms of the CRG work in the region and the support that the Stop TB partnership has provided to specific CRG interventions at the country level, we have indirectly supported the rollout of the CRG assessments through the Global Fund TB Rep 2 project implemented by the Center for Health Policies and Studies, so the PASS Center. The CRG assessment really is the starting point from which CRG principles, approaches and interventions can be operationalized. So it really is good to see the uptake of these assessments in your region. To give you a flavor of the types of information generated by these CRG assessments and how it is used, most importantly, I thought I would highlight what the assessments in Tajikistan, Kazakhstan and Kyrgyzstan revealed in terms of number one, key populations prioritized, the human rights and the legal concerns, as well as the challenges facing different genders and how stigma and discrimination are all impacting access. And number three, I'll touch upon some of the recommendations that were taken forward. This information that I will present upon is just a summary, and it draws heavily from the publication Breaking the Silence, Human Rights, Gender, Stigma and Discrimination Barriers to TB Services in Georgia, Kazakhstan, Kyrgyzstan and Tajikistan and Ukraine, which was developed again as part of this TB Rep 2 project funded by the Global Fund and implemented by PASS Center. The publication was developed by PASS Center and their consultants with contributions from the Global Fund CRG Department, Stop TB Partnership and the WHO Euro Division. So using the CRG assessment protocols that were developed by the Stop TB Partnership and most importantly adapted by countries, these qualitative assessments provided an important baseline, as is outlined in the report, to establish the situation of TB key populations, the state of human rights, gender and stigma-related issues, and how they impact program performance to reach and treat the most vulnerable. So if we take Tajikistan, the CRG assessment conducted in 2020 and led by the NGO Gender and Development with support from the Global Fund CRGTA program, namely the Canadian Legal Network, they prioritized several key populations and for the following reasons. People who use drugs have a higher risk of drug resistance in Tajikistan, and while OST is available, its coverage remains low, which is impacting people's ability to complete treatment. People living with HIV, people who inject drugs, and sex workers express not trusting the health system, which again creates barriers to access. Tajik migrants do not have access to adequate and affordable health care, while in the Russian Federation, and upon return to Tajikistan, they are not prompted to screen for tuberculosis. People with a history of imprisonment reported challenges in terms of accessing a TB diagnosis or care while in prison, and upon release struggle with accessing care because they don't have the appropriate IDs or documentation papers. So therefore, at an individual level, these populations are either not seeking or are not able to access services, which in turn is impacting programmatic performance. In terms of gender, women's decision-making power in Tajikistan, according to the report, in relation to health is very limited, especially when it comes to those who have lower education levels. Married women also fear divorce, while unmarried women fear finding a partner. Gender norms is also impacting access. So, for example, due to masculinity norms, the main function of men in the family is to bring money home. So when Tajik married men are making money abroad, it is usually sent back to the male relatives on the husband's side of the family and not necessarily the wife, which then further contributes to women's disempowerment. As such, one could deduce that in terms of gender responsiveness in Tajikistan, it would be both recommended to have not just a gender sensitive approach, but also one that is transformative, which could balance out these inequalities. So now in terms of human rights and legal concerns, Article 1.56 in the Health Code, according to the assessment, lists the rights of people with TB. However, the Health Code does not prohibit discrimination of people with TB, even though the same prohibition exists for people living with HIV. Furthermore, it is reported that people with TB feel insecure about their labor rights and right to social support. And in terms of stigma, low public awareness about TB and treatment is creating fear, which means that people are not actively seeking care. Now in Kazakhstan, the assessment was conducted in 2020, and it was led by the Kazakh Union of People Living with HIV in collaboration with the NTP. Kazakhstan prioritized two populations, people living with HIV and internal migrants. So internal migrants, according to the report, often face challenges with housing and job security, which leads people to prioritize job seeking over health seeking. And people living with HIV experience delay in getting a TB diagnosis because TB/HIV integrated services are not always available at the health facility. Now, in terms of gender, women experience elevated levels of stigma and discrimination, which impacts their ability to access health services. Women with small children in particular experience delays as well in getting a diagnosis because of the lack of childcare support. And for men, like in Tajikistan, they prioritize job security over seeking care, and they have elevated alcohol and drug issues in comparison to women, which can also interfere with treatment adherence. And in terms of human rights violations, people reported having been fired from their job and even being expelled from university. In Kyrgyzstan, the assessment was conducted in 2016, and it was led by the TB Coalition with support from the Global Fund CRG department through APMG Health. So in Kyrgyzstan, people who use drugs, prisoners, internal migrants, and people with a history of imprisonment were prioritized. The assessment revealed several barriers faced by these populations. So migrants, for example, and people with a history of imprisonment struggle with access because they don't have the appropriate IDs or documentation. People with drugs struggle with treatment adherence, because in some cases, healthcare providers ask hospital staff to discontinue OST while on TB treatment. In terms of gender, women with TB can be subjected to physical, emotional, and also sexual violence because of TB. And women in Kyrgyzstan have also been advised in some cases to abort their babies while on TB treatment. And for men in Tajikistan, and like in Tajikistan and Kazakhstan, delays in health-seeking behavior occur in Kyrgyzstan because they're often the breadwinner in the family and they prioritize their job over health-seeking. In Kyrgyzstan, there are also several regulations and policies which contribute to legal barriers for people with TB. In the law of the protection of the population against TB, there is a list of professions which prohibit people from TB from accessing. Furthermore, people with TB are largely not aware of their rights, and the contact investigation policy and practice used at the time of the review in any case did not respect people's right to privacy. In other words, contacts of people with TB could not were being reached out to without the consent of people with tuberculosis. And in terms of stigma, it is highly prevalent in primary healthcare settings, according to the report, and myths and misconceptions about TB are really fueling stigma in family and community settings, again, presenting as barriers to access. So as part of the CRG assessment, countries proposed recommendations. So the next step after the assessment was conducted, they proposed recommendations and actions to overcome these barriers through usually a national dialogue that is a consensus-driven process. And in Kyrgyzstan, which is really good news, because the assessment was conducted in 2016, their findings and recommendations were used to inform the funding request of the Global Fund in 2017. So in other words, this was an example of how CRG information was concretely used to integrate CRG into the national TB response. So today as well, across the globe and in several other countries that have conducted these assessments, they are now translating these findings from the assessments into what we call costed CRG action plans, which are then being integrated into national strategic plans. So just by way of an example, in the Democratic Republic of Congo, 8% of their total NSP budget is now allocated to CRG. But coming back to the solutions and to the findings, again pulling from the Past Center publication, countries propose to address the barriers faced by people who use drugs and people with a history of imprisonment through service integration and comprehensiveness, training the police and prison staff and orienting people affected by TB to their rights, just by way of some examples. And in terms of gender equality, to address the consequences for TB for women, countries propose to disaggregate all indicators into men, women, and other genders, which will help to really monitor and to design appropriate gender comprehensive interventions, gender responsive interventions. They also recommended providing family planning support and to address gender-based violence. In terms of stigma in healthcare settings, countries proposed improving working conditions, including prevention and infection control, developing and implementing protocols regarding confidentiality and training healthcare workers on key populations, gender, human rights, and so on. And finally, to address quality and people-centered care, countries proposed to strengthen case management to meet the comprehensive needs of people affected by tuberculosis, ensuring and protecting people's rights to confidentiality, providing differentiated treatment options, and making psychosocial and peer support available to all people with TB. So as is outlined in the Past Center publication, there are several differences, but also similarities in CRG barriers and solutions proposed by countries in your region. But for me, I guess the take-home message, which is also in the report, is that progress is really being made in your region to reform TB care, so that it is responsive to the needs of people affected by TB, so that it is patient-centered or people-centered, it is rights-based and driven, it is gender-sensitive and transformative to really meet the needs of key and vulnerable populations. And so to further support your efforts, the Stop TB Partnership is here to support, as you know, Dr. Andre Masniaga's work through the Global Fund and USAID, as well as through this grant mechanism that I mentioned called the Challenge Facility for Civil Society. So this year, we're really pleased to be able to announce that we'll be working both at a regional level in the ICA region, as well as at country level to support efforts in Tajikistan, Kazakhstan, and Kyrgyzstan. So in Kyrgyzstan, we'll be able to, through the Challenge Facility, to support community-led monitoring and advocacy efforts. In Kazakhstan, we'll be able to support the development of a national CRG costed action plan, which is great news, and as well as community-led monitoring and reaching key and vulnerable populations through innovative innovations. And in Tajikistan, we'll also, through the Challenge Facility, be able to support the development of a national CRG costed action plan, as well as community-led monitoring and interventions to reach key and vulnerable populations. The Challenge Facility really traditionally has only been able to support a small number of countries, but this year, really thanks to the USAID and Global Fund and their considerable contributions to the Challenge Facility, we're able to support a much larger number of countries. So this year, we're able to support 28 countries and 6 regions. And so myself and my colleagues, we're really, really pleased to be able to support the region more concretely through the Challenge Facility this year. So with that, I will close and congratulate you on all the CRG work done thus far in your region. And on behalf of Stop TB, express how much we're really looking forward to continuing our work with you on CRG this year.
Esteemed participants, despite the fact that Mrs. Smith was not with us, we had beautiful presentation of hers from the point of view of voiceover and the presentation, but we still have the great opportunity to ask the question, any questions to the representative of Stop TB program, because we have their full participation. So please, if we do have the chance to ask questions from them, should you have any of them, or would you like to ask them, you may do this.
Regarding the issue of the human rights, involving the community, gender equality, there are practical application through analysis of five countries, 3 countries from this Central Asian region. There's already good experience using this, utilizing resources, and then those barriers need to be overcome, and grouping these barriers and summing them up as general for all the countries and also specific for each country in the region. Also, if you paid attention, if you notice, the last message, in the last message, it was pointed out that there are reforms already underway in this regards, and they already launched the reform process. So there's a starting point for that, and I think that these reforms will be successful in the future. That's why this presentation was really very interesting, and it supports us in continuing our endeavors that we started. Thank you all, and I will give floor back to Mr. Nasidze. Thank you very much, Rita. In my turn, I would like to now present our last presenter, Dr. Ron Martin Hughes from the Institute of from Australia. Dr. Martins has education in the area of mathematics and informatics, and he has a PhD. So starting from 2015, he headed and supported several analyses of economic modeling and increasing the efficiency in allocating the resources, fighting TB, HIV, and malaria. And we all understand, everyone present here will all understand how important it is to allocate resources during planning activities and efforts and in the fight against tuberculosis. So he also has the development of models of optimal TB. I know several reports optimal TB for several countries, and these reports are always interesting. And I will now have the opportunity to listen to Dr. Martin Hughes with his presentation on this very topic on optimal TB. So, Dr. Martin Hughes, floor is yours.
Thank you very much for the introduction and the invitation to share today. So yesterday and this morning, we've heard, I've heard many wonderful presentations on improving TB care, on the implementation of TB services, improved diagnostic routines. And what I'd like to talk about is the allocation of resources between each of those. So when we've got new prospective programs and existing programs, how can money be spent most effectively? Because when we think about sustainability of TB services, that really means being able to sustain funding and demonstrate that TB spending is as efficient, cost efficient as possible, in order to maintain funding from governments when there are many other health issues to respond to, and from funding partners. And so that means demonstrating that we're achieving the greatest impacts we can with the amount of money we have. And so that's for the right people, as in the presentation just now, looking at key populations, how well are we targeting our spending to reaching those who are most vulnerable to TB, or those where can be the highest yield of testing. How well can we target it to the right places geographically? Is it more cost effective to increase spending in one district or in another district? In the capital city where the burden may be high, or in the more rural areas where cases are going undetected? Are we spending money at the right time? Often the answer is that the right time is now, but how many more infections TB infections, TB related deaths can we avert if we invest more money this year compared to if it takes 10 years to reach that level of investment? And are we investing in the right ways? So with limited resources, is it more cost effective to invest in prevention, TB prevention, for preventive therapy, or is it more cost effective to invest in a better but more expensive treatment regimen? And so when we conduct analyses, we're looking at questions like, after generating a baseline with mathematical modelling of the current epidemic and what the projections are, there are questions that we look at, like, can we spend money more effectively given all of the current programs or prospective programs? How can we spend that more effectively? What if there was decreased funding in the future or increased funding? What programs would we cut if we had to reduce resources? And how many more infections would there be as a result? Or if we could generate increased investment in response to TB, where would we allocate that? And how can we justify that to the people who would be providing that funding? And in particular, when we look at those NTB targets, as we've heard already, mostly we're not on target globally for reaching the NTB targets. So how much more investment would be necessary to reach those targets? So in conducting mathematical modelling, optimization, there's, I guess, several key inputs to this process. So one of those is to generate the projections through of matching all of the reports of incident TB cases, of how many people are being treated, what the treatment outcomes are, and ensure that that matches what's being seen in the country. And the second part, which was really well summarized by Liliana as well, was having really accurate descriptions of the programs and the unit costs, how much, and having that done with consistent methodology so that we can understand what those programs are doing and what the impact will be, and how much they cost relative to each other. And then it's really critical to include realistic constraints on this optimization. So the constraints can be ethical around just maintaining treatment, even where it's more expensive. They can be economical based on available resources, potentially with what increase in spending is realistic, or they can be around what the objectives are. But most importantly, they can be around logistical constraints. As mentioned just in the previous the previous speaker, not all key populations may be accessible for treatment. And so it may not be possible to reach 100% coverage or even 90% or even 50% coverage. And so it's important to input all of those constraints in what can realistically be achieved and hopefully to include programs, additional novel interventions that would increase outreach and increase the potential to reach a higher coverage of key populations. And once we have each of these inputs, we can run scenarios to analyze how, what the impact of changed spending or improved program efficiency would be. And most importantly, we can run optimization of spending. So we have an algorithm that runs, and I won't go into the details, but it's on our website. But the algorithm generates, reallocates all of the spending between different TB programs. And that gives us projected outcomes. So I'll give a couple of examples of how we've applied these models. So one of these was in Belarus in 2016, about five years ago. And the spending at that time was around 25% of spending was being spent on involuntary isolation for relatively few patients, very high cost, while hospital-focused treatment was nearly 40% of all of the spending in the purple color. And of testing, most of that was being done through mass screening. And so through this optimization process, and in line with recommendations and very much in line with the experience from Kyrgyzstan, the first speaker this morning, reallocating that spending to optimize the outcomes, recommended a reduction in involuntary isolation, a shift from hospital-based to ambulatory care, and moving away from mass screening to better targeting that to the people where there's higher TB prevalence. And as a result, it's possible to achieve much higher rates of TB diagnosis and more people on treatment. And that has implications for sustainability as well. So the projections of what that would achieve, comparing the current conditions or the current conditions as of 2016 to the projected results with the optimized spending, be a 45% reduction in active TB prevalence and nearly a 60% reduction in TB-related deaths. So the results of spending money more efficiently, even when there is, I guess, resistance because of how historically things have been done, the outcomes from spending money more effectively can be really quite significant. Second example I wanted to talk about was from Indonesia. And so this one we conducted recently. And Indonesia has one of the highest burden countries on all measures, including total TB cases, TB-related deaths, drug-resistant TB. But the current spending is really almost as efficient as it can be because they have quite limited resources, like a 45% funding gap to what they would like to have. And most of the money is being spent on treating people who are diagnosed through passive case finding, people who attend clinics because they're sick. And so there's actually quite limited achievements. So this analysis was focused on what can happen with more money, with more resources. And of course, acknowledging within that response, most of the analysis was done before COVID, but the impact of COVID there is that 20 to 50% of health providers have reported disruption due to COVID. And really it's not on track to have any reduction at present based on our projections. And here, even with if we quadrupled spending, even then the NTB targets wouldn't be within reach. And that's partly because of the implementation of programs. And I think my colleague, Dr. Kai Lin, will speak about the implementation efficiency within settings such as Indonesia later. But reallocating spending is not quite enough. But what we can do is have a more realistic target, looking at an amount of spending that the government could put into programs that are known to be effective and that can achieve really tangible outcomes. So when we look here at a 15% projected reduction in TB incidence by 2035 relative to 2016, that's quite significant in Indonesia and translates to 75,000 fewer TB cases per year, 15,000 reduced TB deaths per year. And that's an amount that perhaps the government can be more receptive to, or funding partners can find resources to fund. And so being able to demonstrate how the most cost-effective programs, in this case, preventive therapy for high-risk contacts, including children and people living with HIV, demonstrating that TB money is being spent as effectively as possible is, I guess, the way forward for sustainability. And it's been great to hear the other, that is a consistent theme. And just to finish, this has really been done as partnerships, and more than the mathematical part of the modelling, it's the process can be, I guess, extremely enlightening to really closely review those costs, closely review what can change, where there are constraints, closely review what new interventions could be introduced in each country. And this has been done, in particular, I acknowledge, I guess, the World Bank for funding much of this development and being our partners and collaborators, along with University College London. And it's not just Optima TB, I guess there's also many other TB modelling groups that are providing similar rhythms, and there's the TB Modelling and Analysis Consortium. So thank you. Hand back.
Thank you very much. Thank you. It was a very interesting presentation, and I hope that the audience can find the details of each report on the websites that you have provided, and I think it will be really interesting for the program managers indeed. Unfortunately, we are running out of time, and we don't have really time for the questions and answers. But anyway, I would have one brief question to you, which I would suggest if you will write in the Q&A answer to this, that if there are any countries who has changed their approach in the financing after your reports. So that will be really useful information if you can write answer to my question in this Q&A. Thank you so much. Огромное спасибо всем.
Thank you very much to all the presenters this morning during this panel. Thank you, Rita, for collaboration in this session. And unfortunately, we don't have time. It's very unfortunate. We already maxed out time allocated for the plenary session. We don't have time for a Q&A session, but I think that in any case, we'll have the opportunity to answer some of the questions at the very end, at the end of the day, when there will be a summary of today. Please, if you have questions, write them down or send them via chat, and our presenters will be happy to answer those questions. Now, I think I need to declare. I think I need to announce coffee break now, which was announced earlier. We already maxed out our time, but I still think that this is how we're going to do it. So thank you again, everyone. Please, please, other moderators, get ready. Please let me know if it's not a time for coffee break. Please let me know. Thank you. Thank you very much, dear speakers and listeners. I would like to remind all of you that in order to participate in the fourth modeling session, you will need to reconnect to the second link for participation in the third session, stay in this link. Now I have a 10-minute break. Thank you.
Добрый день, доброе утро, уважаемые участники конференции. Позвольте вас поприветствовать на сессии номер 4.
Dear conference participants, I would like to welcome you to session 4. And session 4 is titled Way for Self-Reliance, Digitalization and Electronic Systems in TB Care. So the session will last 1 hour and 20 minutes, and we will have a number of guests, presenters from all countries represented at this event. And I would like to present to you the moderators of our today's session 4, Dr. Dilaram Kasimova. She is the country director for the USAID project, Eliminating TB in Central Asia. This project is implemented in Tajikistan and in Uzbekistan, as well as in Kazakhstan. My name is Sharaf Yuldashev, and I'm the senior advisor for TB for the Global Fund USAID STAR project. And this project helps Uzbekistan's NCP. So at our today's session, we will have 6 presentations, and also we will, so for the following topics. The first is data mainstreaming of TB information systems in Tajikistan. So the presentation will be made by Anbar Giyasov. The second presentation is on experience with video-supported treatment in projects in provinces of Uzbekistan. So USAID Eliminating TB in Central Asia project, Alexander Tropnikov will make this presentation, supported by Sherzod Rahmarov. So next is video-accompanied treatment of TB in Uzbekistan. Dmitry Subbotin, representative of NGO Intellige. Presentation 4 is alternative options for treatment monitoring in the context of COVID-19 pandemic in Kazakhstan. The presenter is Panagul Jazibekova, and the next presentation is introduction of DHIS TB tracker in Uzbekistan. And a representative of Oslo University, Yuri Rogachov, will make this presentation, supported by Mike Frost. And the final presentation for this session is prospects of TB-MIS in Kyrgyzstan. And this presentation will be made by Timur Gubayev. So next, the session will finish with questions and answers. And the plan is to give 10 minutes per presentation. Please stick to that time limit, because finally, with participants of session 3, we will have to reconvene and discuss the results of our discussions in session 4 and session 3. I guess I would like to open this session with the brief message that rapid development of information technology offers a lot of opportunities and to introduce innovations in healthcare, in TB care, namely to provide better access to TB services. So more intense and of higher quality information exchange becomes possible, and introduction of innovations, which is happening globally. So now our session will discuss improvement of reporting, registration, and moreover, improvement of care delivery for our TB patients. So once again, thank you so very much for joining us. And now I would like to give the floor to Anbar Giyasov. He is the information technology expert for USAID Eliminating TB in Central Asia project. So he works in Tajikistan. He has more than 4 years experience with TB, and he is a specialist in TB register. So you have 10 minutes, and the floor is yours. Thank you so very much, dear colleagues. And now I will make the presentation on data mainstreaming of TB information systems in Tajikistan. And so as part of digitalization of the TB service, now we are active in implementing a number of information systems.
Да, в рамках цифровизации, если ориентироваться...
Минуточку, пожалуйста.
Одну минуту. Давик, продолжи.
Не, ну мне кнопочки дадут сначала.
Нет,
если
я имею в
можно.
виду, продолжи обозначь, что просто меня подключают, поэтому у тебя
все,
забрали панель.
поняла. Спасибо, Малик. Дайте, пожалуйста, мне тоже кнопочки.
Коллеги, я могу продолжить?
1 минуту сейчас переводчикам раздадут панели. Спасибо.
Спасибо, спасибо.
Уважаемый хост, вы дали, по-моему, только одному переводчику.
Уважаемые коллеги, у нас технические моменты, так что можете пока более подробно ознакомиться с нашим каскадом и с теми информационными системами, которые мы внедряем, то есть мы планируем или же внедряем в рамках национальной программы. То есть во всем каскаде у нас внедряются вот следующие информационные системы.
Анвар Атхамович, продолжайте, пожалуйста. Мы по ходу будем решать вопрос презентации. Спасибо большое за терпение.
Спасибо. В рамках цифровизации ТБ-службы на данный момент активно разрабатываются несколько информационных систем, а также в каскаде вы можете увидеть те информационные системы, которые уже функционируют в нашей республике. Я бы хотел сделать обзор существующих информационных систем, систем, которые на данный момент разрабатываются и внедряются, и информационные системы, которые планируются к внедрению в Республике Таджикистан в рамках национальной программы. Начнем обзор то есть информационная система, которая разработана для надзора и выявления, диагностики и лечения больных туберкулезом. И внедрение данной информационной системы начался с 2011 года, и по сегодняшний день данная информационная система обновляется, улучшается.
Is being updated, improved, and this information system includes the following reporting forms: TB03, TB03U, and the reporting form TB07, 07U, Form 8, all reporting forms which are approved by the National TB Program and the country. Since 2018, the National TB Program decided that all reports will go digital with the support of this very information system. So this information system, since its launch, aimed to ensure the following functions, like just find patients, to get the accumulated reports on patients, and actually this system in terms of these functions operates quite well. And also we have the laboratory module, which has information on laboratory tests. The next information system which is functioning in our country as well is Aspect. So previously that system was titled GeneXpert Alert, and it connected all laboratory devices, GeneXpert, into one database, so it collects data from those machines. And currently the country is at the stage of upgrading GX Alert to Aspect, and after that upgrade, the expectation is that the system will support not only GeneXpert devices but also other laboratory machines like MGIT and BACTEC. And now this system Aspects unites 55 GeneXpert machines installed in all provinces of our country. So the next functioning information system is Prevent TB platform, and this information system aims to detect and report and provide clinical assessment and screening of vulnerable groups, and in testing for infection and treatment of patients. This platform is recommended by WHO, and it was selected by the NTP as a primary tool for screening of vulnerable groups and contacts. The adaptation and implementation of this information system began this year, 2021. And this system includes 3 modules: the mobile application dashboard, where you can accumulate data, aggregate data, and also smart setup module, with which you can configure the system. So as for information flow in this platform, it looks as follows. So the first, the volunteer visits the target household and registers the index case. Then this is followed by contact screening for symptoms, and based on the presence of symptoms, the decision is made whether to give a voucher, and if there are certain symptoms, the voucher is issued for testing for active TB. And if there are no symptoms, a voucher is given for LTBI testing. And depending on the testing results, the health professionals reach a decision if to send the patient for repeated testing or to finish the algorithm here or to enroll a patient to treatment. And the benefit of this system is that it informs the health professionals and volunteers if throughout this chain there are any gaps. Say if a contact fails to timely undergo testing following the issuance of a voucher, then the system issues a notification. Then you have to check this case further. And another information system is which is so we started implementation and adaptation of this system this year, but the need for these symptoms, the systems, the relevance of such systems increased during the COVID-19 pandemic, so video supported treatment. We followed the example of other countries. We began to implement the video supported treatment system. So it's like I like VST. Also, our joint effort in the country resulted in the development of the document, the data management strategy for the TB labs. And this very document outlines the IT landscape of the TB service, and it describes the available computerized system. So if you take a look at the existing IT landscape, so you will see that now we have two fully functional information systems. So GX Alert would to be upgraded to Aspect and the laboratory module. So as you can see, not all areas of the cascade are covered with information systems, and our primary objective is to cover the whole cascade. And I made an overview of the information systems using which we want to cover the whole cascade. And the last slide in my presentation shows technical issues, and the information systems which I've just described are shown on the slide. I mean, the links among those information systems at the level of primary healthcare. So we will use a Prevent-TB platform. So the main users of this system will be volunteers and health professionals at the primary care level, and then we plan to introduce the laboratory information management system, which will operate at the laboratory level, and our existing information system, which collects information from provinces, from the devices installed there. It will be directly connected to the LMIS, and all the data will go into the integrated database. And also links will be ensured between the laboratories and clinics. And as I said before, clinics are using the MIS Open MRS. And on top of that, we also provide VST in clinics and two information systems. As you can see, so far they are not connected, interconnected. And in the future, the plan is such systems will be developed and introduced in the country and in advance. So we are planning the following connections. Dear Anbar, please stick to your 10-minute limit. Your time is almost done. So that's the last slide. I'm about to finish. So there are two information systems, so IMR and DHIS. So they will be used at the country level, and all accumulated data will be shared between these systems. Thank you. If you have any questions, we'll be happy to answer. Dear colleagues, thank you very much, Anvar, for your presentation. So should you have any questions, please write them in the chat. And when we have questions and answers session, so we can follow them, but the time is limited, and I would like to present to you our next speaker, Александр Борисович Трубников.
В одной команде. Он очень молодой, так скажем, но в то же время очень опытный член команды.
But at the same time, he's very experienced, and he's got a lot of experience working as a clinicist for 10 years. He's a physiatrician, so before he entered our project, he was deputy chief doctor of Tashkent City Center of Pulmonology and Physiatry. So his presentation will be about implementing the experience of the implementing a monitoring system in the Republic of Uzbekistan. Esteemed participants, ladies and gentlemen, thank you very much for a very nice introduction. Yeah, I'm happy to be part of this project, but since we have a very short time for presentation, so I'd like to talk about the experience of USAID Central Asia Tuberculosis Elimination Project experience in Uzbekistan and in the piloted areas. Next slide, please. Beautiful, thank you. So as for the background, I may say that the work that carried out in recent years in the Republic of Uzbekistan, the widespread introduction of digital technologies in the social sphere, also sets a priority tasks for the application of electronic services within the health care system. So based on the decree of the President of the Republic of Uzbekistan, PP 4191, we've referred to that decree several times, but there is also an appendix, which is the subject of our discussion as well. So, and that based on that appendix, we were able to start our activity. I would also like to tell you briefly what is the VST. It is video supported treatment. That's the provision of individualized human-centered TB care and support services based on information and communication technologies and digital health tools. So it becomes a very good ground or platform for following, monitoring, and also treatment. So I would also like to say that video controlled treatment involves the interaction. So, and it allows a person not to go to the medical facility, healthcare facility. So I would also like to emphasize that based on the initiative of the National TB Control Program and the country WHO office in Uzbekistan, there was this working group established, technical working group established in the Republic of Uzbekistan to develop national clinical protocol for the organization of video control treatment of the TB patients. And following that, the training models has been developed based on that work. So as for the level of urgency, we may say that there are certain factors which are challenging the treatment and they are hindering directly controlled treatment. So first of all, sometimes people do live quite remotely from the medical institutions. Then that's why, and due to other factors, there is low patient adherence to treatment and low income of some patients. So it is difficult for them to cover travel expenses. Another limitation, there are certain limited capacity of the healthcare system as well. Not always we may transport to the door to door. Not always we may provide door to door drugs to the door of the patient. As for the Central Asian experience, we were able to perform 3 stages already of implementing the VCT, the video control treatment. So first of all, it was planning, then customization, and then deployment and support. So as for the a planning increment. So together with the NTP, we were able to analyze the regions, and we started up two pilots, one in the city, in urban area, that was Fergana Valley, and then one in rural area. So, and then we've covered also Margilan city, Margilan, the town Margilan, from the Fergana region. And as for the rural area, that was the Farish district and Jizak region. So we've allocated financial support, and it was funding provided for deployment, and the whole concept has been implemented, and we were able to procure specialized equipment to provide the VCL, and also equipment for the provision for the medical staff has been purchased, and communication equipment has been procured, and also we've trained 25 experts on how to perform the treatment. So as for the timeline, on May 11th, the first patient was taken to the VCL in the city of Fergana. May 24, there was first patient in Bayut, Sirdarya, and then June 3rd, training course has been conducted in Farish district in Jizak, and June 24, Margilan town has been also integrated. So, so the first patient has been introduced from that. So it was weekly communication with the pilot regions on technical support and mentoring assistance. Yeah, can we have next? No, we're going backwards. Yeah. So let us discuss the numbers with regard to experience of the implementation. As for all the persons that were undergoing the outpatient treatment, so VSL, out of the outpatient treatments, 42% has been integrated to the VSL system. And if we will be discussing direct numbers, then currently we see that in the majority of coverage is there in Fergana region, and then Sirdarya 17 and Jizak only 4. So in Fergana 21 accordingly, the highest. So here's the age characteristics, or the age disaggregation. So in all groups, there was somewhat about a similar number of patients. So there are no complications for elderly, truly, in applying the VCL and using VCL. As for the rural area, or city versus rural, out of all the patients, it was 50-50 truly. So 50% urban area and 50% rural area. Next one, please. Now, as for equipment, despite the fact that the project procured equipment both for healthcare personnel and for the patients, I'd like to emphasize quite a positive factor. Majority of patients, as you see here, 29 persons, they were applying their own equipment. So they were using their own internet connection, and we didn't have to support them on behalf of the project. Neither the hardware nor the internet was provided to those. So besides, we would also like to say that unfortunately, there were 2 patients who we had to remove from VCL. So first patient has been withdrawn due to lack of skills in applying the equipment and using the equipment. So until he had an assistant, like younger family members were next to him, then later on he was unable to use it. So we had to bring him back to the outpatient treatment. And number two, there was another patient. So he was temporarily suspended VCL, we would say, so due to hospitalization. So in a somatic hospital. So, he was unable to send videos anymore to us. So I'm sorry, that was the one who was hospitalized, but then he came back. The previous one was another one that has been withdrawn. So there were two patients that were removed completely and one who was temporarily suspended, and now he is back on. So as conclusive remarks, according to the preliminary estimates, 42% of people with TB in the project areas, in the piloted areas, are covered by VCL at the outpatient stage of treatment. So video-supported treatment guarantees controlled intake of medicines, which is good, great. So it means that every time they intake medication, so it's controlled by a medical nurse using video communication. So, and should there be patients who are unable to administer their medicine at once, they can do it at different times without getting linked to a certain time of the operational hours of the certain office. So there were no difficult for them to operate. So it doesn't matter how old were the patients, where do they live, in rural area or in urban area. So, and also there is no need to get high additional costs. So because, as we told you, 71% of our patients were using their own internet connection and the equipment. So, however, the interviewing procedural nurse as well, and there is an increase in the temporarily workload of watching those video messages. Well, this is it. Thank you very much for your kind attention. I'm passing the floor back to our moderator. Thank you very much, Alexander. It was a very interesting report of yours, and that's very interesting and new type of treatment provided in Uzbekistan now. So allow me to pass the floor to continue the topic to back again to the representative of our republic, another organization that works in Uzbekistan to implement video treatment. So that's the Republican Information and Education Center, Intelish, and Dmitry Subbotin will provide you with the information about video-supported TB treatment. And this activity has been implemented by coordination within the working group that has been established, and we've referred to that. So our national protocol has been developed based on the work of that group, and in piloted regions, the USAID using actually current messengers and Intelish, they moved even further. So they've developed their own application for that. Thank you, Sharaf. So our experience, I will share it with you. First, let me introduce myself. I'm a manager of the project in Uzbekistan, and that's the project under USAID. So since the coordinator is unable to join, so I will be able to respond majority of questions that you probably would have, but if not all of them, then we will pass on the questions to my colleagues. Well, under the framework which is supported by Global Forum Fund in partnership with Stop TB project, so we've adopted an application to be applicable actually, and it's actually development of a multi-partner development, I would say, and one of donors to financial donors, of course, it is Stop TB Partnership, and I will show you the list of those organizations who took part in implementing that. So implementation date from March current year until December current year. So here are the partners. So you have to take into account the background, right, when you develop this or that product. So here are the organizations, the partners who took part in developing the previous part of the development. So Ministry of Healthcare in the Republic of the Republic of Uzbekistan, and in particular, specialized Medical Center of Pulmonology, our organization, so Intelish. So the project, the objective of our project was to apply it in Tashkent only first. So to do like-to-like comparison, to compare other partners, like previous presentation of Alexander has shown and covered the description on how the project ethic is moving forward, and I will be telling you about our successes. So our task was to adopt a software, an application, and to subscribe 50 patients, clients. So just two objectives. One, to get prepared to the process, and number two, to perform. So what exactly has been done right now? So the intermediate results. So first of all, the first objective has been already covered. Then the content. So the content we had to translate. So we did it into 3 language versions, Russian, Uzbek in Cyrillics, and Uzbek using Latin alphabet. So just recently, on the 1st of September, we were celebrating 30 years of anniversary, and the younger generation, they are freely using Latin alphabet, but senior adults, they feel more comfortable in applying Cyrillics. So then adaptation of the software, of the application, there is a comprehensive number of activities. It's not only translation of the content or transferring the content. New images had to be developed, had to be generated for us to communicate with actually to have the local customization, let's put it this way. So, and our adaptation of the software was also localization for Uzbekistan. So the server, which is like where the software is located, it is currently located in Uzbekistan because it's the requirement of our new legislation. So then we had to remove all the errors, any type of errors, typos, you name it. And then quite soon, maybe devoted to this conference, 10 patients has been already integrated or subscribed to that software. So we have 2 versions, mobile software or application and web version. So which means that you may access it from 2 devices, from both of your devices. 3 languages, as you see. So it is multilingual application. Next one. The address of web version is there. Mobile version you may get. Well, we are now in the moderation period for the Play Market, so Google Play Market. So a second item will be done quite soon. It doesn't mean that it will have free access for any user, because the access to that particular application will be regulated by the doctor, actually. So not you won't be able to download it out of curiosity, truly. So the server for the applications, for all the applications, is located within the territory of the Republic of Uzbekistan, and it's done based on the internal network TAS-IX. So, and it will be free of charge for the locals. So it is free and easy to access. So functionality of the software and the application for the patients. So first of all, it is the guide on how to take the video. Besides, we will also provide the training support. Then I don't want to repeat myself, and actually not myself, but my previous speaker. So the treatment can be done at any time. Then there will be a video recording, control over the health condition of yourself, and information about TB. So the system works very well. There is basic information about nearest anti-TB healthcare facility.
And the list of patients, their health status, so the adverse events already reported. So my time is up. See, I apologize. Can you remove it? So feedback is also available. And it's also the option to send messages, and upon request from the patient, the doctor can respond. And also there is the video archive of such messages. And the next slide shows the screenshots inside the application. So you could see to what extent it's convenient. I think it's really convenient. And this is the list of patients enrolled in treatment and the archive of video records. And you can see a number of icons. You can use them to view video, to verify video in terms of quality. And this is about viewing video, and you can respond to video message here. And also you can rate it if it's a high quality video or not. After that, our social workers step in. So this is the component, like interaction with the civil sector. And if for some reasons a patient can't shoot a quality video, then we provide more advice for the patient so they can do that. Then on the right, you can see a convenient tool to sort and find the videos. And these are 4 tabs required for doctors, which make it possible to prescribe treatment regimens, but actually not about prescribing. It's about entering the information on prescribed treatment regimens here. And also you can describe the outcome, the alterations in the treatment regimen, so you can report adverse events and the results of their management. And also you can view trends with regards to body weight and overall health status of the patient. So this is analysis of adherence. Yeah, this is the primary objective for us for the civil sector. So we have to make sure that all new patients engaged in VST could get ones, so there are no gaps in terms of taking drugs. And this is treatment control for patients without video. Again, it's an objective for non-government organizations, so we could work with relevant patients to improve it. This is the summary for all patients. It's like the aggregate information for health organizers, for health managers, so they could assess the results. And analysis for side effects, and you can see here, you have the general list, and also you have the list of the latest adverse events within the last 24 hours in need of urgent attention. So this is the list of benefits of this application, and if in terms of the content for those key benefits, like no need to visit the health facility, remote control, no need for the internet when you take your drugs, and feedback with the patients. So in general, this is the list of VST benefits in general, but during the presentation, I guess you could see to what extent the quality of these benefits as a result of using specialized applications. So quality in this case is higher compared to using non-specialized resources, and the primary difference and the primary benefit is you can access the personal verifying records because you have easy access to your video archive, and you can do the assessment retrospectively at any point in time. Now we will analyze the cost effectiveness, the economic model, and we will see to what extent it is feasible to have this specialized application. It's about it, or maybe we will for manual compiling of tables. So we will see until the end of the project. The plan is to develop the educational course for the specialists to be engaged in the new provinces of Uzbekistan in this work. So thank you. I apologize for taking more of your time. Thank you. Thank you very much, Dmitry. It was a very interesting presentation. Again, colleagues, I would like to remind you, please write the questions in the chat, and when we have the final revision of the session, we will ask our presenters to answer your questions. And now I would like to present our next speaker, Panagul Jazibekova. Panagul now is leading the Monitoring and Evaluation and Epidemiology and Statistics Department and Digitalization Department of the National TB Center of the Republic of Kazakhstan. And so she has more than 24-year experience as a TB doctor. She's a doctor of the highest category, and also she worked as a dean of the department of the medical department university in Kazakhstan. And also she was engaged in a number of projects initiated by Project Hope and Partners for Health, and now she runs this very department. Her presentation is on using alternative options for treatment monitoring in the context of COVID-19 pandemic in the Republic of Kazakhstan. So please, the floor is yours, Panagul. Good afternoon, dear colleagues. Thank you for the introduction. I would like to highlight the digitalization of TB service. It began in 2003, and since then, annually, we are improving our information system. So this is the National TB Register of TB cases. And in this register, we report each and every patient. So not only TB patients, but also the contacts. So who are monitored as part of each and every dispensary group. And then at the year end, using this register, the reports are generated plus since 2013 in the civil sector. And since 2014 in the penitentiary sector, the system was switched to the online mode. And this is very convenient because you can get access from elsewhere for all specialists at all levels. And this information system actually checks the daily take of drugs, and this is the general information on our system. So in 2019 and 2020, some adjustments were made to our mode of operation, and the techniques previously used as pilots, as pilot projects have become relevant. And out of alternative treatment monitoring techniques, we were using, of course, the traditional control technique in the primary care facilities, also in the hospitals, and for patients with little children or for elderly patients, for disabled patients. So home-based treatment was provided at some point in time, and nurses daily bring drugs to their homes. And for 2 years, we've been using mobile teams, and as opposed to home-based treatment, a mobile team also can search for patients, and mostly it is used for patients from the key population groups. And as mentioned by our previous colleagues, so video-supported treatment, and this has been in use since 2016 as part of the project implementation, Partners for Health. So when new TB drugs began to be implemented in the country, so gradually we started that VST. And we could see this technique is effective, and since 2018, we are rolling it out nationwide. And compared, so as opposed to my previous colleagues, I can say that we have no special application. Maybe we will adopt your experience, dear colleagues, because so far we've been using the applications available now, like a video call via WhatsApp, a video record, or maybe a Skype and similar applications. And in the last 2 years, actually, some half of the patients receiving outpatient treatment have been using this treatment mode, and that's how we control that. Also, on top of control, we provide social support to patients receiving outpatient treatment, which also improves the patient treatment adherence. So nationwide, now monthly patients receiving outpatient treatment receive also financial support. So in different amounts, but the country is working towards unifying the amount of the support to avoid differences. So we have the country indicator as the minimum, and we can stick to that. So it's like 5 or 10 minimum, and this is given to each patient, and it improves the adherence. As for VST, so the NCP approved the practical recommendations. Cascade training was provided for health professionals. And these recommendations have criteria for VST, selection criteria, actually. Like the first is outpatient treatment. The patient is willing to use this treatment control technique. Also, informed consent should be signed. So we work with the patient on how to use it, how to call, how to store drugs, and so the time is specified when the communication has to be made. And then on the vacation, on weekend, so the patient sends the video record. In case there is interruption, no communication with the patient, so the patient might be switched to the regular mode of control, meaning he has to visit the health facility. And in case the patient is willing to continue and there are no gaps, the patient might be brought back to the VST. And of course, he should have access to the internet, and he has to know how to operate a tablet. And then provincial centers for patients procured smartphones, and for nurses, they procured tablets where they didn't have enough. And so it all is procured. And plus, if the patients can't pay for the internet, the TB centers can pay for their internet connection, so they can daily communicate. And the social memo was developed for the patients, meaning they need to indicate date and time, show what drugs they are going to use, and also transparent glass should be used, and relevant steps should be followed. And in 2020, more than 4,000 patients were on VST, and now some 5,000 patients receive a video observed treatment. This is very convenient. And now, to what extent, like the patients really use the drug? So we have the information system for drug utilization. So nurses who have control of VST or at the PHC level. So daily, when the patient receives drugs, they put a tick in this information system, so it is more financial, so like invoices and financial information on how many drugs were utilized could be generated from based on this system. And daily writing off drugs is available in this interface, so daily patients access it, and there are relevant records for all drugs. And maybe it's not really convenient, and maybe it's duplication, but this is the national information system, National TB Register, and this is the page with the names of drugs, how many should be taken by each and every patient, and when the patients use drugs, then they note it here, and it's a plus, and in our plus shows when they have to use it, and when they use it, then they put a ticket. And so it's about treatment monitoring. And now, to make it easier for the personnel, work is in progress to integrate the two information systems. So information could be entered to the National TB Register, and from there it could be transmitted to the drug management system to avoid the double entry process. And so now we also use distance monitoring techniques. So in general, TB interventions monitoring. So now we use that distance monitoring. Initially, we were opposed to that. How come distance monitoring? But now we do understand that we are on the right track. And daily, our specialists do that monitoring. We have the responsible officers in provinces, and they work with provincial teams. And in their turn, they monitor the lower level of health facilities once a year, or maybe as indicated twice a year. We do outreach monitoring, so we go on site and see. So this is dictated by the time. So we have to use these techniques. And thanks to all those techniques, in our country, the treatment effectiveness remains quite high. So as for DSTB, 87%, as for DRTB, it increased given the introduction of new drugs, and now it's 82.5%, the treatment effectiveness. So which suggests that we are on the right track, and then this work will be improved further. As I said before, possibly we will adopt the experience of our colleagues when you don't have to communicate daily via the internet and ask for reports as a result of VST. Now they are manual, and then it's being embedded into the information system, and maybe we will use some of the applications. And what's not shown in this slide is in the country, now we are pilot testing in 6 provinces. We are using jointly the past agency, the application, where patients also can ask questions on all aspects of TB, adverse events of TB drugs included. Thank you so very much for your attention. I will be happy to answer your questions. Thank you very much, Panagul, for your presentation. It was very interesting to take a look at Kazakhstan's experience, especially using various information platforms. And I hope that the experience you have now, presented in a limited number of slides, of course, your experience is extensive enough. And I hope our colleagues implementing DST now will have an excellent opportunity to share experience with you. And dear colleagues, thank you so very much for being with us. And now I would like to switch to the next presentation. This is the presentation titled by Introduction of DHIS TB Tracker in Uzbekistan. And I would like to say that the presenter is Yuri Rogachev. He's the leading expert of Oslo University, IT expert. So Yuri, we are pleased to welcome you to this forum, and please stick to your time limit, 10 minutes. Yuri, the floor is yours. Good afternoon, dear colleagues. We are pleased to join your conference, and our presentation will be made in English, and we will split it into 2 parts. So first, Mike Frost will deliver the first part, and then I will complement on the epidemiological surveillance part.
Great. Thank you, Yuri. And thanks for the chance to speak with you all this morning. I'm just going to do a quick overview of what DHIS2 is, and then turn it back over to Yuri to give you some specifics about how we're using it for TB in Uzbekistan. I'm Mike Frost. I'm here with the University of Oslo, based in Norway, and supporting DHIS2 globally. You've heard it mentioned in the previous presentation from Tajikistan, just very quickly what it is. DHIS2 is a free open source platform developed by the University of Oslo. It's been a project here at the Health Information Department for the last 25 years. It's made to work within the browser or in Android, and it's specifically made so that countries can own and manage their own health information systems. It's used for many different areas in the health context. TB is one of those that we have a specialty in and have been working in for many, many years. And we work very closely with colleagues at the World Health Organization and are supported by the Global Fund and many other global health agencies. Just a quick overview of our global footprint. DHIS2 is used by over 90 countries. Some 60 plus of those are nationally scaled health management information systems and using DHIS2 to support across the health streams for vaccinations, immunization, COVID, surveillance, many, many different purposes. Just a quick slide to show you the different organizations that are supporting DHIS2 as a platform, and a couple of slides here that you'll have access to that will show you where you can download and customize and use DHIS2 for your various health programs. But what I wanted to refer to more specifically around TB is University of Oslo is a collaborating center with the World Health Organization. And as part of that agreement, we have developed specific configurations of DHIS2 that are meant to respond to key disease areas. These are versions of DHIS2, again, that are free and available to download, to customize for your specific needs. And they are meant to help countries to be able to have very high quality information systems that are responding to global standards and global recommendations for analytics and for patient care. So you can see that we have put together a various number of TB packages. Documentation for all of these are available online, and you can download these packages as well to install them in your own servers. We cover for tuberculosis, we cover aggregate reporting, logistics, case surveillance, the DRS, and there's ongoing and continuing development in these areas with some 40 plus countries that are using DHIS2 for their TB programs. Just showing you a couple of quick screenshots of what the various modalities are in DHIS2 for data entry and analytics. This would be a very simple kind of look at doing reporting, monthly reporting, information coming in from kind of district level, regional level, those feeding into national indicators. We also have the more specific individual level data in the DHIS2 tracker side of things. You can see if I were a clinician here logging in, I perhaps have 7 or 8 different programs that are covering the areas where I provide health services. TB can live alongside your programs for immunization, for cause of death registration, birth notification, any number of programs that are available to add to your installation. Part of the benefit of this is that once DHIS2 is rolled out for any one program, it's very easy to start to add additional health areas for those same clinicians. They don't have to go to various different systems for reporting or for collecting data. They can stay logged in at their site and continue to enter information based on what patient they are seeing and what their health condition is. Again, just a quick look to see kind of what it looks like. This works across the web, which is the far left images, or in Android. You can have users on both parts, depending on what is best for the use case and what their internet connection is like. The Android version of DHIS2 works offline, so they're able to continue doing their work even if they don't have a persistent internet connection. All of the data that you collect then is available for analysis, pre-configured analytics, mapping, graphs, charts that can be based on the indicators that you want to take a look at. And Yuri will take us forward now, taking a look at specifically what we've done for configuring these packages for use in Uzbekistan. So I think with that, I'll stop sharing. Yuri, I'll let you go ahead and share.
Thank you, Mike.
Спасибо.
As Mike has mentioned, the UIO team, the University of Oslo, has been working on developing the standardized modules in various health areas for individual and aggregate data collection. For TB, we have a published aggregate data collection package for quarterly and annual reporting, a TB logistics package, a TB tracker package for case surveillance, and DRS, anti-TB drug resistance survey. Together with the WHO country office in Uzbekistan and the regional WHO office in Copenhagen, we have started working on the adaptation of the TB tracker package for Uzbekistan. And I will, in a few details, describe what this adaptation work implies. So as DHIS2 is a multilingual platform, we started by translating the platform itself and the metadata configuration, so the TB module, into 3 languages. So into 2 versions of the Uzbek language, so the Cyrillic and Latin transcription, and Russian. Currently, we're using Russian as the development language for the adaptation process. We started adopting the package by creating an organization unit structures and the user model for the system. So in close cooperation with the NTP in Uzbekistan that have developed an adaptation protocol for TB package, we have set up the facilities, the regions, and the hierarchy structure, as well as the country-specific workflow. So what you see in the screens that I'm sharing here is on the right. You can see a map of Uzbekistan with division and into regional district and facility levels, which can be very handy when using the analytics and showing the indicator values in the GIS system, so on the maps. What you see on the left is the basically working list of a facility level at the stage 1 of the facilities in Andijan, where we have an overview of the patients that are entered into the system. So as well as the adaptation for the country-specific workflow and adding different variables, we have considered the readiness for the interaction of the DHIS2 system with other systems in place. On the next slide, what you can see is the data entry form of the TB case surveillance system. And this is what a data clerk will see on their screen, with some information provided and summarized at the top of the screen, and the tabs for entering data into the system. So the program itself, the TB case surveillance, it's aligned with the WHO definition and reporting framework, and based on the data that is captured in the system, we can generate aggregate data for quarterly TB reporting and notifications. So this data can be entered on both web interface and in Android. And here you can see that we have certain stages in entering data. So registering a TB case, we have the various laboratory results, the treatment information, and the outcome. So on my last slide, what I will show you is that the data that is entered into the system is later aggregated and then rendered into the reports. So in accordance with the reporting standards in Uzbekistan, we have designed reporting forms within DHIS2 that match the currently existing report forms. So what you see on the screen are the so-called the quarterly report forms for TB case notification and outcomes on the left and on the right-hand side. And we have successfully tested these report forms with the anonymized data that we received from the NTP in Uzbekistan. So in addition to these reports, a lot of work has been done on the extensive SSV08 report that is also included in the system. Not all the data that is currently captured in the tracker, also in the individual model, can be rendered into this report. So we run a combination of individual data entering and the aggregate data entering. So, but as the DHIS2 offers a lot of flexibility in itself, so it is possible to further adjust the system in the course of the pilot, which has been identified for specific regions in Uzbekistan. I think this is, in short, what I wanted to say about the program, and I will be happy to answer your questions later. Thank you very much.
Спасибо большое.
Colleagues, thank you so very much for your presentation.
This presentation was presented by Yuri Rogachev and Mike Frost. Thank you very much. From University of Oslo, Norway. Из университета Осло, расположен в Норвегии. Давний партнер национальной программы.
They are quite long-term partners of ours, of the project and of WHO. Dear colleagues, questions and answers is section started up already, also on chat and also in YouTube. You may ask your questions. We will be able to accumulate them, and we will also voice them during the final session after 11:40 in Tashkent, like before lunch. So our next speaker, next expert, it is Timur Tabagatovich Pugaev, USAID, TB Kyrgyzstan. Cure TB, that's the name of the project. Timur works as an expert on medical IT technologies under the system of the number of projects Cure TB. He's got the experience in business for 5 years. And his presentation will cover perspectives of TB treatment in Kyrgyzstan. 10 minutes you have, Timur. Thank you very much for presenting me. I can hardly hear the speaker. Well, his microphone is very far from his face, I guess. So interpreter will be guessing. So when we start to look into the beginning of the activity, it was quite difficult that time when the experts and healthcare personnel, they had to fill out a lot of documentation. They had to work with a number of reports. It was quite difficult for them to process a lot of data that was covered in those documents because it was very much fragmented and located in different places. So this is why the redundant information was presented. So it was quite a mess and quite horrible approach in doing analytics, and the reports which are done in handwriting or in the way of just printed paper. So it was quite impossible to aggregate and then to analyze that. So document turnover is always in need of place to store all this data and archive them. So as for medical information system, so it is a comprehensive automated system, the one which I'm referring to, which is applying and performs automatization for all business processes. It covers the support of adopting certain decisions at every level of healthcare system. Do you have presentation maybe, Timur? Oh, I'm actually showing it. I'm sharing my screen. No, you didn't do share screen. Thank you, moderator. Thank you so very much for telling the presenter to speak up to the microphone. Closer to the microphone would be very helpful for the interpreter as well. Do you see it now? Yes, we can see it, but we still cannot very much hear it. Besides, under the program, we may see the situation with regard to the condition of a certain patient. It can be done both on Android or with the help of any other type of digital units. So the main idea to implement and to develop medical information system in the anti-TB system. So first of all, it is to provide for automated approach in managing the whole system, and also to apply the wide range of use of digital systems. So we have to provide clinicists, lab workers, the heads of healthcare system with the information for them to be able to make decisions based on the valid and modern data, up-to-date data. So automatization of all business processes, as I told you already before, within the healthcare system, and also to transfer it immediately to the electronic base approach. Also, one of the main aspects here, which is needed to be reviewed while implementing this objective, while following this objective, is to provide for the personal data safety and protection of personal data, actually. So to provide also computer and network equipment to the healthcare units. That's the good ground for the system to be operable, actually, and to be applicable, because without that, digitalization cannot be performed. Besides, another important aspect is to improve the level of knowledge and skills of medical personnel, healthcare personnel in the area of computer literacy, training on how to apply newly developed software products. So that's another very important step. Currently, the medical information system covers information processes, which is linked to different clinical lab and biological matters. Starting from 2014, when the primary program started to be implemented, well, at the level of healthcare, we were able to implement at the level of centers several software products to cover information system to manage the lab data, like TB registry, actually. So we also were able to implement a following system, and that's the pharmaceutical store, drugstore. So that's the architecture of the medical information system and TB as well. So digitalization in healthcare system, it is just a tool that improves the number of indicators in the healthcare system. This concept, which we see on the slide, so we apply the ISO model on digitalization that foresees electronic healthcare to cover all the components of this architecture. Different systems can be also integrated to that particular hub, and they may apply one interface to work all together, to be interoperable. So the system that has been presented at the upper part of this slide, those are the parts which we were developing while covering the whole system. So it covers all important parts for the registry. And as you may see, we split them by colors. So it's color coded. So different conditions of the system can be color coded. And so those in bright colors, like it could be clinical statistic information.
LSME.
Or LMIS, so these systems are developed already, they are existing, and what you can see as highlighted in blue, it shows the module is being developed. So the beige shows the systems are missing, but they are planned to be developed. So then we can state our systems are linked to various systems of ministries and agencies, especially health ministry, and ministerial systems might include various systems on various areas, and now we are connected to the civil registration system, so to the marriage registry, so to ensure the identification of a Kyrgyz Republic citizen, and it's about getting access to personal data. And if we are referring to health information system, so we can highlight the information on pharmaceuticals. And now we are connected to the register of health facilities, and we are getting information from them, and also on their codes. And now all basic TB MIS systems are connected to the system itself, which helps standardize interactions among various information systems, and it streamlines the interaction itself. So organizations who want to get connected to this system are offered one standard. This interaction follows, and it's a benefit of the system. So the interagency interaction system is connected to the state portal, and citizens can get information after identification. And if we focus on selected systems, so this slide now shows you the electronic record case file. So there is connection to various databases of documents, and also connection tools for clinicians could be provided, so where patients receive treatment starting with identification till the final outcome. So you can see on the slide, first there is registration of patients following the unique ID, it's personal ID, and then insurance status could be checked, and referral to a doctor. When a doctor receives the information following registration, he can see the treatment history if the patient was previously treated TB. Then information from the State Health Insurance Fund could be obtained on previous treatment regimens and on other conditions related to TB. Plus, the doctor prescribes treatment. Then automatically this information is sent to other TB by MIS. And plus, this system also has information on drugs provision. So the doctors daily fill out forms, and also information is provided in turn for the nurses. So Timur, I'm sorry, but you just have 1 more minute or 2 minutes at most. Thank you. So as for the information system, the laboratory data management, so first of all, it's about automation of the work of laboratory experts. So data could be shared. I mean, data obtained from laboratory machines. So not only persons are connected working in this system, but also machines are connected. And such machines as GenExpert could automatically send data to the LMIS. So the system makes it possible for doctors to diagnose quickly and to prescribe treatment, because data electronically are available online and there is no need to access laboratories. For more information, plus it is patient specific. It means that each specimen will be linked to patient, and thus there will be no mistakes in the system. And if we discuss COVID-19 module in that system, so it was a separate module. It was implemented in 2020 when there was a pressing need to implement that connection of public laboratories, so they could ensure accurate patient identification and links to test results. So following testing, patients automatically receive information via SMS. So a patient can access the system using the link given to him on their own. And information can be provided not only to patients via SMS, but also digital signature could be used if they use the state portal and using the digital signature in the cloud or just regular electronic signature. As for the number of laboratory tests in the LMIS, we can see the number of COVID-19 tests is way higher compared to the number of TB-related tests. And now it is 856,000 tests. And we have the electronic TB register, which was implemented in line with the requirement to ensure primary and final patient registration prior to the stage when the final outcome is entered. So also the module for case-based treatment was implemented for the state health insurance fund. So verification can be ensured to what extent the treatment was of high quality or not. And then again, we are using here the interdepartmental electronic interaction system, and the TB register covers not only the primary level but the secondary level as well. And thus the patients now in hospital, they can be put on treatment, and then the case file is not sent anywhere and no data are lost because it's all automated. It's all about interaction among information systems. And then we use the personification, so no duplication of data here, and various information systems can share data here. So now LMS connects more than 92 labs, and we have 1,192,000 entries. So as for electronic TB register, 81 has facilities, and as for the electronic system, so more than 20 hospitals are connected. Thank you very much. Sorry, I took more of your time than planned. Thank you, Timur, for your presentation. It was very interesting. And now I would like to invite all our participants, and then I would like to encourage them to download all the materials. Please take a closer look at the presented experience, because it describes several systems interconnected. If I got it right, in the Republic of Uzbekistan, we are on the threshold of launching several systems, and the issue of harmonization of their operations is also to be addressed. And in this case, the experience of Kyrgyz Republic is very important as well. So colleagues, now we have questions and answers session. In the chat, we could see one question already answered, and now we suggest we accumulate all the questions for the next session, when we will sum up the results of session 3 and session 4. So now session 4 participants, please get back to the main hall where information is provided on the quality of drug procurement as part of the state procurement system. So, but now if you have some quick questions, we can accumulate them now and we can provide answers. Dilarom. Thank you very much, Sharaf. So in the chat, we got one more question for Anvar Giyasov. So how will you address the issue of data accumulation, and on what servers will you store information from TB screening and referrals for diagnosis? I guess you are referring to Prevent TB platform, which is about testing contacts, referring them for diagnosis. Anvar, are you here? Can you answer this question? He is not online. Then I guess so I can respond because this is done by Etica project. So the data will be installed on the MCP servers, and then there will be connection to the Open MRS system. The point is that Open MRS, so the various options will be considered. So Anvar is here. Anvar, please respond. Okay.
Коллеги, прошу прощения.
Colleagues, I apologize. There were some technical issues. Thank you very much for your question, Dilarom. You've correctly mentioned. We plan to install the server at the National TB Center. All data will be stored there, and for the connection, we have the data management strategy, this document, and we are considering all possible links among those systems, various systems planned to be developed, and the information systems which exist already or are operating in the national TB program. So we plan to talk to the system developers so they could ensure links among those systems so they could share data. I hope I answered your question completely. Thank you, Anvar. It seems we do not have any further questions, and then the parallel sessions will sum up their results. And thank you. See you there.
врачам, самое главное, пациентам было легко воспринимать, так как мы знаем, что если мы будем осуществлять государственные закупки, не всегда может удастся именно закупить те препараты, которые будут идти из средств гранта глобального фонда, а мы входим в те страны, где еще сохраняется большая доля в денежных средствах именно в произведении закупок, и были бы расхождения именно в некоторых позициях по некоторым препаратам. Например, если мы будем закупать для половины когорты один препарат из средств гранта глобального фонда через GDF, а из средств бюджета они будут поступать, так скажем, из других производителей, то и для врачей, и для больных было бы трудно объяснить это именно нашим пациентам. В связи с чем мы решили выбрать именно использовать
whether they are here. I see Katie. Yes, fantastic. Can you unmute yourself to check whether everything is fine?
Yes. Can you hear me correctly?
Absolutely. And Nana?
Yes,
Nana
do you hear me?
as well.
Yes.
Excellent. We do at this time have 18 attendees. Let's give a bit of time for other colleagues to join us in this session. And we could continue also for the administrators and the host of our session. Could you please elevate the presenters to the role of the panelists? Nana, Katie, I will leave it to you for deciding when we could start. I would assume that we could do, considering the fact that we have also an online translation as well as the recording that can be viewed later on. Back to you.
I don't see the number of participants, so it's very hard to me to.
Yeah, if you click on the participants, then.
Okay.
So we do have translation going on, excellent. And then we have 21 participants. Okay. And we'll kindly ask the administrators and the host of this session, the secretariat, to ensure that the presenters are elevated up to the role of the panelists so that they could present. I would suggest Katie and Nana to start the session. Back to you.
Thank you very much, Andrei. So this is a very logical continuation of our previous session on uptake of new drugs, because this session is also dedicated to operational research, mainly on MSTR. And this session will be moderated by Dr. Andrei Dadu. I know everybody knows Andrei, but I will still introduce him. He represents infectious disease program at WHO European Office. He's a medical doctor from Moldova with postgraduate training in the field of epidemiology from Emory University. And since 2007, he's been with WHO, mainly involved in TB programs, focusing on TB screening, prevention, research, and development, and so on. And Kathy is a medical doctor working as a TB advisor in MSF since 2005, and her role is advising projects, MSF projects worldwide on different aspects of TB control program, particularly on uptake of new drugs. So we heard Kathy's presentation recently. I will not be long then. And myself, I am Nana Zarkov from Uzbekistan, working as a TB advisor in USAID STAR program. STAR stands for Sustaining Technical and Analytical Resources. So I think maybe we can now start presenting the participants. Katie, over to you.
Yes, great, thanks. Yeah, so I'm really honored and very excited to be part of this session. It really is exactly what we need. It's about operational research and how it can be a catalyst for improving and introducing new options of treatment for patients. So I think that we've really seen that in the previous sessions already how it can work, and we've seen how it can really accelerate the implementation of new strategies, and it can really lead us to innovate and develop new models of care. So I think that in this session, we have a little bit of everything about how we can learn about it. So we've got the presentation on the sorted course for the first one. We've got some results coming from Kazakhstan. We've got some lessons learned coming from Tajikistan. We've got very important information about pharmacovigilance, which is part of operational research about safety from Kazakhstan. And then we've got our last presentation about how to roll it all out. So we've got it all in this session. So I'll go straight introducing our first speaker. So our first speaker is Dr. Jamshid Gadoev. So he's going to present some information about the sorted course, which is the structured operational research and training on TB. And he is from the WHO country office in Uzbekistan, here in Uzbekistan, and has a long history of working in TB and some great experience that he's had with the Damien Foundation and others. So I'll hand over directly to you, Dr. Gadoev. You should turn on your...
Yeah, I see Jamshid in the main hall there, and he's handing the microphone on. Before going to Jamshid, I would kindly reiterate once again, dear participants, the audience, please do not hesitate to either raise your hand, chat in the chat box, commenting the content provided to you, as well as raising questions in the Q&A chat.
Добрый день, уважаемые коллеги, уважаемые участники нашей конференции. Меня слышно?
Do you hear me well? That's the presenter speaking already. Do you hear me well? The presenter is asking. Okay, good, beautiful. Thank you so very much, Andrei, Catherine, Nana, for giving me this great opportunity to present and also to moderate as well, for your moderation of this topic. I would truly want to talk about the activities that has been performed in the framework on RTB, and that's with regard to operational researches that are being ongoing here. So under the ERI, European Tuberculosis Research Initiative, together with the Ministry of Health, our WHO country office in Uzbekistan were able to organize a country-specific structured operational tuberculosis research training, so SORT TB. So, and I've just mentioned that it is structured operational tuberculosis research training. So there's a couple of words, couple of items regarding background. So that was the initiative that was financially supported by joint WHO/KFW project, TB prevention and control in Uzbekistan. So the training course, I don't see it there, but that's okay. So the training course, SORT TB, was conducted in the Republic of Uzbekistan between 2019 and 2020, and it was co-facilitated by the officers from WHO Regional Office for Europe, the WHO Country Office in Uzbekistan, the International Union Against Tuberculosis and Lung Disease. So let's call it Union in France, and international experts in the area of tuberculosis research. Well, we truly wanted to have our colleagues, medical experts, who are highly interested in having scientific research. This is why we have invited especially those experts. So we have announced a call to participate during these training courses, and that call has been approved and done and then sent, channeled actually using the MOH channels. There was this deadline, but before the deadline, we were able to get 23 applications from the participants for them to get participation. But after the deadline, another 15 additional applications has been submitted. So they were late in getting information about that. So out of those 23 applicants, we selected us, who is us, independent team that gathered 13 candidates. We've selected them to attend SORT TB. So the minimum requirement were fluent knowledge of Russian language and data access availability. Knowledge of English was preferable. The selection was based on the eligibility requirements as well as matching of the research proposal with national and regional research priorities. So the training course has been launched on 30th of September 2019. So, and then those who don't know about that, what was the whole meaning of that? SORT TB covers 3 modules, 1, 2, and 3. There are 3 of them. First and second modules, they were conducted in the end of September till the mid-October. So, and it was conducted back-to-back, so dealing with protocol development, ethics application, and data capture, validation, and analysis. So the modules were directly trained in Samarkand, and it was like face-to-face training, like we get used to it before. So then during the third module, we were able, during that particular modules, we were able to provide them with number of data on how to get data, how to perform validation. The information has been provided with regard to development of the database for their own operational researches, and they were applying the platform AP46. So each and every participant would develop their own database applying AP46 and with the help of our experts and our colleagues. Between second and third module, somewhat about 6 months should pass for the participants of those training courses to be able to gather needed information. And some of them, they gather the information about cases, clinical cases. Some of them are gathering just information, individual information using the questionnaires, etc. So 6 months is devoted to that. But unfortunately, COVID-19 happened and the third model was delayed because of that, and we were able to help them together 14 months later, so because it was delayed, and it was applying the online format, so it was done like virtually. So despite those challenges, a lot of data has been collected. We were able to analyze it, and the manuscripts were written, so there were articles produced, generated. So we have applied to the international journal, and there was impact factor of number 3. So they are indicated in number of scientific platforms. So we've submitted 13 articles, and one editorial has been submitted to that journal, and it is the International Journal on Environmental Research and Public Health. And the project which we submitted as well. So, and that was operational research to inform programmatic approach to management of tuberculosis in Uzbekistan. 12 articles, 12 manuscripts and editorials successfully has been accepted by the journal, and some of them are under the process of peer-to-peer review on behalf of the editorial. So we truly hopeful that they will be selected and approved, and that would be great. So we will have 100% publication of the results. So here's the list of those publications which has been published. So first column, the main researchers, the country, so chief investigator, then the country, and it's always Uzbekistan, of course, then the area of research. So this is how it was done on the, and then it is downloaded to the website. So we have 12 articles over there, it's obvious, and there are some pictures there from the training course, and the participants actually, and the way they were trained, the way they worked. So it is all being reflected. So you have, if you're interested, you may have the access to those articles following the link. So this presentation will be also part of the archives for our conference. So the access to the archive will be sent to you via link. So, and that's the direct link to that publication. So you will be able to download those articles if you're interested to. So on behalf of our WHO team, on behalf of the joint team, I would like to express our deepest gratitude to European WHO office, and in particular, Mardanova Nurdida, who is the assistant and assistant head of the program, JTH, for her commitment and assistance in performing this training course. Thank you very much for your kind attention. Thank you very much, Jamshid. It was very interesting to listen to you. Dear participants, it was provided one of the examples of prevailing or disseminating the skills of performing operational research at the country level. So as you well aware, it was done within the framework of the European Research Initiative. Please look back to the chat. There is additional information and links that has been passed on for your information. And right now I'd like to switch to our next speaker. That will be Yerkin Bulat. Can we have your camera turned on, and please start sharing your slides. Erkibulan, that's the partnership in health. So he is based in Kazakhstan. Partners in Health, yes, right. So, and he will be presenting us with a presentation that will be operational research, evaluating efficiency or effectiveness and safety of all oral modified shorter treatment regimens among those patients who has been enrolled to that investigation, to that research in Kazakhstan. Erkebulan, please. Good afternoon, my dear colleagues. I represent Partners in Health. Erkebulan. I cannot share my screen somehow. I'm sorry. Secretariat, could you help me, please? Yes, thank you. So today, I will share with you the operational research results that has been conducted to perform evaluation or assessment of effectiveness and safety of all oral modified shorter treatment regimens, MSTRS, and it's funded by Global Fund and by the Partners in Health. So this research, as it has been already mentioned by Askar, so the protocol is approved by a local ethical committee under the National Scientific TB Institute, and also WHO Ethical Committee has also approved that in October 2020. So the main objective of that research was to assess the effectiveness and safety of shorter treatment regimens for RRTB with duration of 39 weeks. So taking into account that this is an operational research, so up to date, we are unable to roll it out for the whole country. We just cover 5 regions. So Akmola, Karaganda, Jambul, Turkestan, and Atyrau regions. Before launching or before we actually gathered patients for that, we've selected patients, we had to perform a number of training courses in all the regions. So all the physiatricians has been trained for them to get acknowledged and get acquainted to the protocols of treatment. And we also provided them with the information which has been covered by the research protocols. So here are the schematics that has been used. As it has been mentioned before, the following non-injectional schemes has been applied. And additionally, we see additional schematic. So before we actually, before starting selecting patients for the WHO research, we started already treating them by BDQ, GLM, DLM, LSD, LFX, and Z. Well, we've gathered at 1st of September, we've gathered our patients. So 293 patients has been collected from the Turkestan region, because that was one of the most complicated regions with high burden. So as for the regimes, the majority of them, naturally, there was BDQ, LZD, LFX, CFZ, CS, 216 patients has been treated this way. But as you well aware, based on the WHO recommendations, in any case, if the patient or patients are following individual mode or regime which is applied in Kazakhstan, they are being, the schematic is being selected based on the WHO recommendation. We apply A, B, drugs, and we adding on C drugs, C medication. 30 patients is on during the process of treatment has been removed because of because they were resistant, and there was only one case of non-accepting the drug because it was levofloxacin that wouldn't go well, and there was allergic reaction, adverse reaction. So the person has been transferred for the individual type of treatment. So all other cases, like 29 cases, all others, because there was resistance developed. So qualazimine 3%, rinezanide in different combinations 4%, and ftorhinolone 22%.
So we reported 3 cases of serious adverse events, of them 3 fatal, 1 hospitalized, so due to acute renal failure. And as for the 3 deaths, 1 fatal case was in patient with alcohol dependence. He died of myocardial infarction, and we had 1 death case as a result of COVID. So for 6 months, the patient received treatment. Then, while at the outpatient stage, he got pneumonia due to COVID, and the patient died. And the 3rd case again developed respiratory failure during treatment after COVID. As for changes in treatment regimens, so in 17 patients, in 9 patients, pyrazine was discontinued because of resistance, and cycloserine was replaced with delamanid because of intolerance to cycloserine. And as for information, well, we collect it. Since it's the operational research in the nature province, we have specialists responsible for data collection of information on adverse events. So they fill out paper forms, and then we enter all this information to the digital database. Thank you. That's it. Thank you very much. Well, as for treatment outcomes, it's too early to tell because only 33 patients completed that, and plus 3 patients who died, and the rest of the patients still continue their treatment. And as for loss to follow up, well, we had none of such cases. Well, thank you. And now let us postpone questions till the end of this session. We will group the questions and then we will answer them. So Nana, the floor is yours. Well, thank you, Dr. Yerkeblan, for your very interesting presentation. We will continue this topic. The next presentation is from Tajikistan. Again, it's MSTR research, and Dr. Firuza Saidova will make the presentation. She's a leading specialist in TP Tajikistan. She's the MDR coordinator, and she coordinates the component of the program. And she will share her experience with us of MSTR in Tajikistan. Please. Please switch on your mic, Firuza, and please press F5 so your presentation could be zoomed. And Firuza, switch on your mic, please. Yes, excellent. So now, can you hear me? Yes. So please press F5.
Добрый день, уважаемые участники конференции, уважаемые коллеги.
Good afternoon, dear conference participants, dear colleagues. I would like to present to you the operational research ongoing in Tajikistan about modified shorter treatment regimens. The research is conducted by the National TB Center specialists, and plus technical assistance is provided by partners. WHO, USAID Ethical Project, the Global Fund, MSF, Stop TB Partnership, and the Red Crescent Society Tajikistan. They help us with training of specialists, supervision, informing patients, and so on. As a rule, the operational research was initiated in the country after approval of the protocol by the WHO Ethics Review Committee and the National Ethics Committee. So we were supposed to start enrolling patients in October, but since some time was spent on approval of the protocol, we started a little bit later, and the first patient was enrolled in early December. So first, as for preparations for this study, so we identified the districts for our research. So then we had to approve the protocol for this treatment regimen. We had to train the health personnel in pilot districts engaged in the research, then to identify the budget and engage partners. And of course, install database API info to enter data on patients as part of the research. So the previous speakers mentioned that the primary objective of that study was to identify the effectiveness of modified shorter treatment regimens for our TB only. So it's a fully oral regimen for 39 weeks under the programmatic settings, and the secondary tasks to assess the cumulative incidence rate, the time of onset and severity of serious adverse events and adverse events of special interest, grade 3 and more among patients receiving MSTR. Then to determine the timing of sputum culture conversion, the patients receiving MSTR treatment, determine predictors of favorable and unfavorable treatment outcomes, and assess the incidence rate of drug resistance for MSTR components, and then to determine the relapse rate in cases of reinfection after the MSTR treatment for 12 months after successful completion of the treatment. Research duration is 9 months, 39 weeks, 12 months of follow-up after the research completion. And what I said before, we were supposed to start on the 1st of October and finish on the 30th of September 2022. The patient enrollment was supposed to finish on the 30th of September. But as I said before, since we started later, so now we submitted the protocol to WHO, so the period could be extended till early December. So the location of research, we initiated the research in 2 stages. Stage 1 covers the districts of Republican subordination and 2 districts for 2 provinces in Khatlon district, in Khatlon province. And then stage 1 started on December 4 and lasted till the 1st of March. And the second stage began in March, and then the patient enrollment is ongoing. So overall, in the districts where research is conducted, 183 cases of resistance to second-line drugs were detected, and only 63 were enrolled because they met the criteria. So 120 patients were not included because they didn't meet the eligibility criteria. For example, resistance to fluoroquinolones was identified, and then absence of confirmed DST, either negative result of LPA, second-line drugs, and or culture-based MGIT, and then there were longer cases of longer intake of bedaquiline as part of the previous treatment regimen, and also the patients were taking more than one month other TB drugs as part of MSTR, so they previously received that treatment. Also, there were cases of contacts with MDR TB and osteoarticular TB, miliary TB, and patients with severe mental health conditions and visual impairment, and so they didn't meet the criteria to be selected for MSTR. And this is the ratio. So in 33 patients, resistance to fluoroquinolones was determined. Then for 35 patients, we couldn't get DST to fluoroquinolones, and that's why we couldn't include them. And the repeated cases account for 13 patients. And then intake of other TB drugs is included in this regimen. We had 3 cases like that, so contacts 6. Then bone TB, and we had 18 cases, then severe conditions, mental conditions, and the visual impairment, 9 patients, and also we had cases of low adherence to treatment. And so those are repeated cases, and the doctors said that there was no adherence to treatment before. And so which regimens were used? Shorter regimens. So for adults, mostly we were using this levofloxacin, bedaquiline, linezolid, clofazimine, and cycloserine. And in some of the cases, cycloserine was replaced with delamanid, and for children, we used the regimen that consisted of 4 drugs. This is the breakdown by provinces. So 14 patients from the city of Dushanbe, 25 from districts of Republican Subordination, Khatlan province 22, Sub province only 2. And so the -2 means excluded from the operational research. And later I will mention that. But the initial plan was to enroll 150 patients. And due to the pandemic, the detection rate went down somehow. So as I put it here, detection of susceptible to be in the Republic of Tajikistan decreased by 27.8% in 2020, and detection of DR to be by 37% compared to the same period in 2019. So we started enrollment on the 4th of December 2020, and as of the 1st of September 2021, overall 63 patients were enrolled. So as for the main regimen with cycloserine, 57%, 57 patients in Victoria are receiving this regimen. So because of intolerance to cycloserine, as recommended by the Consilium, they were switched to the regimen containing delamanid, and children are receiving this 4-drug regimen. So 4 cases were excluded from the operational research. 1 died because of profuse pulmonary hemorrhage in the hospital. In 1 case, the tuberculosis of the spine was detected as spondylitis, and she was switched to the individualized regimen. And in 2 patients, resistance to fluoroquinolones was shown by DST, and they were switched to individual regimens. So the adverse events that occurred during the research, so severe reactions and reactions of special interest. So 1 patient had severe myelosuppression. So as recommended by Consilium, linezolid was suspended for 20 days, and then enhanced treatment was prescribed for, and then treatment was resumed, and now the patient is receiving the whole regimen. The one patient on month 4 developed visual impairment, and that's recommended by the medical concilium. Linezolid was excluded, and now the patient is receiving 4 drugs. In 2 patients, we reported depression and because of cyclosterine, and it was replaced with delamanid. And in 1 patient, we had persistent severe myelosuppression, and closer to month 5, the linezolid was canceled, and the patient continues the regimen with only 4 drugs. So here, I've given the results of the conversion for 46 patients covered during 6 months of the first year, and after month 1, the conversion based on culture was reported in 10 patients, after month 2 in 12 patients, and after month 3 in 1 patient, meaning that out of 39 patients, 23 had conversion, and 7 patients included 4 children with the lymph nodes, and they were contacts, no bacteriological confirmation. And this is the results of for conversion, visual presentation, and despite the positive aspects, we are facing some of the challenges during the operational research. So challenges in the diagnostic process. In separate cases, not always LP2 was available, contradicting results between genotypical and phenotypical DST, which complicated clinical decisions, and some restrictions, limitations with regards to DST. And so only DST within 3 months is allowed, and in case of contacts with clinically diagnosed TB and without bacteriological confirmation, so as they are contacts, we couldn't enroll them because DST result was older than 3 months. And it's part of expansion. The new pilots, we got problems with timely receiving of follow-up testing results and entering research data to the FE-Info database. Also, there were challenges with timely receiving of results for control microscopy and culture from National Reference Lab on site. So we had issues with timely obtaining of results, the tests. That's it. Thank you.
Да, Фируза, большое спасибо.
Yes, Firuza, thank you so very much. You made a nice presentation.
I'm going to introduce the next speaker. So the next speaker is Dr. Bates Tuyabayeva from Kazakhstan, who's going to present the pharmacovigilance and the implementation of active drug safety monitoring, or ADSM. And Dr. Tuyabayeva has a very long experience working in tuberculosis, almost 30 years of experience in the field of tuberculosis, and is currently one of the specialists in the department in the National Center in Kazakhstan. So over to you, Dr. Tuyabayeva. Are you able to share your screen? If you double click, yes, wonderful. Okay, thank you. We don't hear you yet. Would you like to say something so we can hear you? Just to check your microphone is working.
Добрый день, уважаемые коллеги.
Good afternoon, dear colleagues, dear participants of the conference, and I would like to present to you the presentation, pharmacovigilance, and implementation of active monitoring of the safety of TB drugs in NCP of the Republic of Kazakhstan. The country has political commitment to ensuring safe, effective, and high-quality drugs, and the comprehensive drug surveillance system has been implemented. Pharmacovigilance in the Republic of Kazakhstan is regulated by a comprehensive package of regulatory documents to manage the drug surveillance system. And the active monitoring is introduced for anti-TB drugs, ADSM, which is governed by special provisions for NCPs developed given the WHO recommendations aim to ensure detection and management of adverse events when treating with new and repurposed anti-TB drugs. And there are guidelines for primary healthcare level, which include the provisions for active drug safety monitoring. And there is interagency cooperation within the country and at the international level. And also the issues of pharmacovigilance are being coordinated as part of the NCP and as part of the common approach, and the function is available for that purpose at the central level of the NCP, and we have the integrated electronic warning system for adverse events. So these are the national regulatory documents.
These are the bylaws and regulations with regard to surveillance. And as for the main activities in this regard, that's the collection and verification of all the messages with regard to adverse effects, then analysis, validation, assessment, and expertise of drug safety data. We also perform monitoring of data on drug safety according to other sources. We evaluate the signals based on the database for the monitoring of the adverse effects, and annually we perform ratio assessment benefit risk of drugs. So there are regulatory measures performed by the committee. So here is the stakeholding entities. Based on the decree that has been adopted, and that's number 320, dated December 2020, regarding adverse effects. So the entity at the healthcare system have to appoint a responsible persons for monitoring of AEs when using drugs. They also have to develop SOPs for monitoring, recording, and providing timely information on the AEs. They have to keep a statistical report on identified cases of AE, and they also have to provide and submit reports on AEs to the authorized health authority. So as for implementation of the ADSM has been implemented by NCP within the framework of clinical and operational research since 2016 in cooperation with international partners. That's the GFATM project, USAID. Since 2018, ADSM has been implemented by the cohort approach with the support of the Global Fund. So then also starting from 2020, ADSM is being used for the strategic programmatic approach and the introduction of new repurposed drugs in general practice while prescribing anti-TB drugs. And in the Republic of Kazakhstan, it is defined for the stage that the main monitoring package and reporting of all SAEs, there is a specialized format for that. So in country, we were able to establish a technical working group under the NCP jointly with National Center for the Expertise of the Drug Substances. A form of clinical and lab monitoring at the programmatic level was also introduced at the treatment of TB with the expansion or rolling out and introducing of those new drugs and treatment regimens throughout the country. And this is all financed from the country allocated budget. For the first time, the pharmacovigilance section with justification was developed under the plan for 2021-2025. A single flow of information has been also provided. So we also have developed job descriptions for those experts responsible for that. And we've performed also TOT training courses, and also the specialized experts have been approved in the regional center. And also we improve the standards, and also lab monitoring and indicators are being introduced to that DAMU-MED medical information system. So as it was informed by how the reporting is working actually, or how the messages are being submitted. So there is an automated information system, and that's a unified or single national database for the electronic submission of information on adverse events. And it's done electronically, obviously. And the name of it, side effects of medicines, SEM, on the official website of the National Center for ELECS and MI, and there is the link to that. So information about the adverse effects of drugs is posted also online on the portal using the login and password, which is assigned to certain medical organizations. So that's the screenshot. Using personal profile, you may enter, log in, and then you fill out the information and also download. So you can also submit a hard copy. So for that, you have to download a template, and you may email it actually. You may send it by email, which is mentioned over there, the address, or using direct link of the website, or you may make a phone call. So as for the algorithm of actions, should there be serious adverse effects detected? So first of all, that's the assessment of patients' clinical conditions for the presence of AE according to the guidelines. Then to provide for the for the medical aid timely. And when the SAEs are detected, a medical professional fills in medical documentation as a follow-on, like accompanying. So, and then when it's also detected, the severity of condition is subject to determination. So based on the severity assessment scale, in each case, it is presented and then reviewed, and information is provided online, as I told you already, under the resolution of the Ministry of Health of the Republic of Kazakhstan, dated December 2020. So should there be a fact of a serious adverse reaction, then within 48 hours after the occurrence of the event, they have to submit the information. So there are only 4 items for minimum information are needed. The patient, the information about the adverse effect, the drug that caused that effect, and the responsible contact who is responsible for the information and who is managing this patient. So we need the age, of course, and the gender of the patient. So the information can be also submitted by a private person. So, and also in the end, you have to put down a date when the event information was received. So that's the system of interacting at the national level. So National Center of Expertise, well, together with Medical and Pharmaceutical Control Committee. So they work together. Within 48 hours, they have to send about serious adverse reactions like death, threat to life, abuse, use outside of the instructions, and unregistered drugs. And then they have to be taken measures to improve. So the committee then, based on this information, they may seize the samples, they may prohibit the use of that. They have to appoint an inspection. Well, and then they may even put on hold or withdraw the registration certificate for the use of that medical drug. So as for the monitoring, under the NRTP, that's the register for TB patients, you can get the number and list of patients who missed anti-TB drugs due to AE. Besides, there is a parallel or synchronized system, ISLO and NRTP, according to the mark of taking or administering TB drug by the patient. Like, for example, so they have to register that the anti-TB drug has been administered or missing. And starting from 2021, there was a lot of work done together with other information systems, like, for example, CMIS, in order to automatically fill out the clinical monitoring form for the patients with DRTB. So which will help the district doctor or primary care to analyze lab parameters or on monthly basis for the AE. So here's the form. So why this has all happened? Because so the person or the patient missed anti-TB drug due to adverse effect or due to the failure in case management. How many drugs, how many times, how many days? So these are the list of clinical monitoring tools for DSTB, which is filled out by the doctor managing the case, the date of beginning of the treatment, main researches, main studies and lab tests, and also the dynamics, which is quite obvious, what changes has happened and everything with regard based on the indicators. Well, that's the back side of the same form. So you may have notes also for the experts, for the doctors, and also for the organization. So these are data from the National Center. And here we have how many notifications or messages from the Minister of Defense has been updated. So majority of all of them belong to anti-TB organizations, 86%. Within a certain period of time. There. We also have an information on the certain sent card messages from the centers. So, and provincial level centers are in that list. So they are sending this information in what category the treatment has been provided. And if it's category number 4, then what type of treatment was received, how many messages has been sent, etc. And here are the type of drugs as well, which were mentioned in the card messages. Sensitivity, number of patients. So what type of what type of treatment has been provided? So depending on type of treatment as well. and how many card messages has been sent. So, and here are the outcomes based on the SAE according to the card messages. So cured, improved, deterioration, hospitalization, continuing side effects, etc. So what are the follow-up steps for the ADSM? So a module training on active monitoring of the safety and anti-TB drugs has been developed with the framework of the GF projects for all the experts, both of the primary healthcare and for the specialized TB healthcare units. So online training of NTB specialists on ADSM will continue until the end of 2021. Creation SOP, development of SOPs, drafting of SOPs for SAE for distribution on TB in the TB centers within all the regions. The introduction of pyridoxine in the form of tablets, 50 mgs in Kazakh national form. So for the whole time of treatment to prevent adverse effects. Then synchronization of informational systems and RBT, KIS, etc. Well, with regard to safety of the medical drugs under the component of MBLA, and also we continue working with NTSELS to receive feedback on card messages at PTP and conduct and analysis to be performed. Well, thank you for your attention. Thank you very much, Doctor. It was very specific and very informative presentation. It is so great that you have such a well-developed system here. Yes, I'm sorry, you wanted to add something? Okay, no one. Let's pass the floor to our next presenter, Stopdan Kalon.
In Central Asia, or Etika as we call it. He's a medical doctor and a public health specialist with 25 years of experience, mostly in the field of DRTB, but he also has extensive experience in HIV, in hepatitis, in emergency interventions. Today, Stopdan will describe the support provided by Etika to successful implementation of TB control programs in Central Asia. The floor is yours, Stopdan.
Thank you, Nana. And good afternoon to everybody once again. Building on the previous sessions, information about the various new regimens that are being rolled out or introduced globally and in the region. And as mentioned by the previous speakers and moderators, so much is finally happening. So my presentation will focus on the activities of the Etika project, how the Etika project is strengthening the clinical capacities and management of DRTB to support the rollout of these short regimens for drug-resistant TB. Highlighting the practical hands-on work that Etika project does on the ground, in close collaboration with the NTB colleagues and communities. Although we work in the entire region, but due to limited time of the presentation, I'm going to focus our work in Tajikistan. Next slide, please. Are you running my presentation, or I'm to share?
You need to share your screen. Yeah, you should share your screen. No problem.
Okay.
Okay, it's good.
Yeah, can you see my?
Yeah, we can see it. Go ahead.
Okay, great. Okay, so just a quick outline of my presentation. I'm going to give you an overview of the epidemic, TB epidemic in Central Asia, new challenges, the project approach, and the key pillars of the clinical component and ways forward. So as I'll not spend much time on this, as we all know that Central Asian countries figure in the countries with the highest rates of drug-resistant tuberculosis and extensive drug-resistant TB. And to add to the challenges, we are confronted with the COVID pandemic, which has made big, serious dents in the progress on years of TB progress. And as we've heard from the other previous presentations, there's been particularly big decline in the detection, case notifications, and screening of presumptive TB. On this slide, I'm just going to give you an idea about the specific the theory of change or the approach of the Etica project. Considering the fact that historically in the region, there are three main areas which are considered as the root causes of the problems, which is the rigid structuring, health systems and financing issues, and resulting in poor quality of clinical care and inadequate involvement of the affected populations, and constrained economic environment, and then particularly with the decreasing funds from traditional donors like Global Fund, and there's with the need to build local capacities and systemic changes to shift from the ineffective, obsolete post-Soviet models of care towards sustainable, high-quality, patient-centered services. And with these rationale, the Etica project theory of change has a holistic approach, whereby the approach is to strengthen the systems, whether it comes health systems or working, strengthening and empowering and working with the communities, and strengthening service deliveries. So, as my presentation is going to focus on the second objective, which is the clinical component of the project, and within that specifically, I'm going to be talking about how specifically it is strengthening or facilitating the rollout of the new regimens. In line with the USAID's global accelerator for ending TB, the main pillars of the clinical component are pharmaceutical management and drug provision, active drug safety monitoring and pharmacovigilance, strengthening the capacities of the clinicians and the medical consiliums, including the medical consiliums at the central and the regional level, and the clinical quality of the clinical care, and also strengthening the capacity of the program and the TB program clinicians and the program managers for continuous cycle of capacity strengthening through workshops and supportive supervisions and other capacity building initiatives. So strengthening of the TB consiliums is one of the major focuses. There's a lot of effort that goes into providing technical support to the TB consiliums at the central as well as the regional levels in order to enable the program to implement particularly the DRTB treatment and with a particular focus on the short regimens. And the approach is of mentoring and a supportive supervision. A lot of the program does a lot of mentorship and supportive supervision at each level. The Etica project also provides support to various other components like the monitoring and evaluation, even latent TB infection, drug management, etc. The project assists the NTPs in also doing, as I mentioned already, to conduct cohort analysis and a new activity that we are soon taking up, that is introducing clinical audit for improvement of the clinical activities for particularly drug-resistant TB treatment. We do conduct a lot of trainings for continuously build the capacities of the clinicians, and the last one was focusing on the introduction of the clinical audit. And then also through particularly thanks to the COVID, we actually introduce use of telemedicine at the different levels in the country, to which was very useful in making online consultations possible, webinars and online trainings for the doctors, and even conducting consiliums at the regional level. This is just to give you an idea about with the support that the project provides, how the enrollments in the different the short regimens that.
I'm terribly sorry to interfere. Would you mind to still continue in the next 2 minutes and then wrap up, please? You have 2 minutes more.
Ah, okay. Sorry. Okay. All right. And then, yes, strengthening the active ADSM and the pharmacovigilance is a key activity, particularly with the new TB drugs and the short regimens. And this is also the same thing for which the Etica project does a lot of work, strengthening the capacity of the NTP. And working for the pharmaceutical management to ensure accurate quantification and forecasting of the drugs to ensure that uninterrupted supply of TB drugs, and also working with the drug regulatory authorities to improve registration of drugs and diagnostics as well. And a lot of programmatic support goes into different aspects of integrated case management, diagnostics and guidelines, and so on, and also assisting the NTP to develop a 5-year M&E plan, and so on. This is just it's an overview of the evolution of the DRTB key milestones. Main part is to want to focus in the OR initiative that started in 2015, and then recently 2016 short regimen, the injectable one started, and then in 2020 the MSTR, and then and also in 2020 BPAL was started. This is just to show how triaging happens to facilitate treatments where the patients, which patients are treated under which treatment. A lot of effort goes into capacity building. I won't go into this. You can see how many people have been trained. This again, capacity building at different levels. And finally, way forward, the project will focus on implementing and strengthening integrated case management, increasing the potential of the specialists in using distance learning systems, and intensify the use of innovative approaches and technologies to enhance TB care. Thank you so much.
Okay, thank you very much, Toddan. That was an excellent presentation. We thank you so much for joining the research initiatives and implementing the innovations through all your activities supported by the USAID. And of course, thanks USAID for the support over the implementation of those activities. We had quite an agile session, I would say. And there is a time to join the main auditorium in the hall number 1. So I would kindly ask you all to leave that session and then go back to link through the link number 1. So that will allow us to join back and then continue the discussions and present what we had in our research session, and then get some additional feedback from the entire auditorium. Nevertheless, do not hesitate to comment. Please continue to raise your questions or even your hand in order to get your contributions and intervention into the session. For now, thank you very much. I believe the session is closed. See you in a second.
Не вопросы, был вопрос для Алтын. Были ли приняты меры в связи для улучшения инфекционного контроля, учитывая результаты пилотирования? И Алтын пишет, что думает, что да, оно не такие кардинальные, да, так что много дискуссий, видно, что нужно продолжить эту сессию. Я хотела спросить вопрос Кайлин. Кайлин, are you still with us? Yeah, I see you are. I just wanted to ask which...
Я просто хотел спросить, какие методы тестов вы использовали в определенного латентного туберкулеза? Это методы ЛТБ было, да? Да, мы использовали туберкулин, кожное тестирование, мы рассматривали другие платформы, включая Kyrich, о котором мы сейчас только слышали, но в контексте было очень много проблем с холодовой цепью, с требованиями, в особенности пока что касается детей.
Я вижу, что в чате написали коллеги, что они закрыли.
I think colleague, they closed their session. So I think, Timur, I think we need to go back to the plenary session. Unfortunately, if I may, one question to Vladislav. So right now we can see many countries use different tests. Somebody uses TBT, somebody switching to agra-assay. Some countries, they use both of them. Do you have any data where countries were switching from tuberculin to agra and how it impacted detecting latent TB? Because it's also very interesting for us for the future, something to... thank you very much, Timur. Yes, there are data, but not from the high level to the high incidence level countries, but from countries with lower incidence rates. But the main advantage is that especially among children, when we conduct testing among children, the number of so-called false positive, not false positive results, but results that are positive in testing and negative in agra, and so these results do not require preventive treatment. Very often they don't even require follow-up. That's why the costs are reduced. So this is the main thing that I can say about the cost effectiveness. Cost effectiveness is a rather difficult issue, but at the same time, we do in our company, we conduct research. Maybe we can offer some instruments for cost efficiency. So the tuberculin tests are much cheaper. You all know that. Agro-assays, I don't think they can compete cost-wise, but however, in terms of reducing need, although agro-assays are not ideal, they're still, they will allow us save money. This is the maybe it's not a very specific question, but this is the answer that I have right now for you. Thank you very much. Then we'll wait. Then we'll wait for the session number 6, and we'll have some time to discuss our presentations, maybe more detailed and with a certain focus. Can we start, or what are we going to do now? Then okay, then we'll start. And so number 5, right?
Я не буду, наверное, сейчас
I'm not going to describe the presentations that we heard today, and you heard them as well. I will only stop in some moments, which I think they were rather interesting, and which I think maybe we need to focus our attention to. The first presentation by Hai Ling Huan. He talked about experience in Papua New Guinea, and what was interesting for us is that a country with high prevalence of TB and MDR TB. So they showed us that this comprehensive approach, cascade approach, inclusion of on active and latent TBs and active TB. It shows rather good results. And we heard about prevention. Preventive treatment, and outcome was really good. This was a good parameter for us because we also very rarely we follow what other countries are doing. We know how many people have started treatment, and we, sometimes this type of information is not available for us. How many people started, how many finished treatment. And second presentation was also rather informative, and I think again the thought from the second presentation, the search, treat, and prevent. It corresponds with the current strategy by the USAID, which uses this is very identical approach. As we follow this again, brings us to think that we don't need to invent a wheel. There's a very effective, efficient, practical models. We saw the examples of some. This was Alaska, New York City, how combination of active finding and rapid treatment and preventive treatment, combination of all three, they radically change the situation and they reduce the prevalence of TB. So we talk a lot about the preventive treatment, about coverage, how it can reduce the incidence by 10% per year. But looking at these tactical results shown, examples that were given earlier, we'll see that this reduction was rather dramatic. This is a very encouraging news for all of us for future planning, so to say. Now, this is it. What I wanted to add on my behalf, I give floor to Ms. Gunta. Thank you, Timur. Yes, we had 4 presentations, and third presentation by Michael Wilson, NVH Advanced and Access Delivery, about rather comprehensive, I don't know how to say it in Russian, but approach to eliminate tuberculosis. It was really interesting to see the history, travel back the history and see how the TB was fought in many cities like New York City, Singapore, many places and it showed us the approaches and experience of the zero TB cities project. And recommendations it was really important to involve local administration, local authorities, all the partners, and create like islands with good models, which could be then upscaled for the entire country, and after that, come up with a network of cities that can share strategies and best practices. Very interesting presentation, the last one by Vlad Nikolaevsky from Gaijin, about the role of IGRA assays in testing in case management for TB for children and adults. And very important thing that Vlad mentioned in conclusion, that to be able to achieve ambitious NTB goals, we cannot but work on finding and treating TB infections. This is just impossible to achieve. And of course, IGRA testing needs to be looked at in the context of testing and treating. Without treating, it doesn't make sense to test. Very interesting presentations. Thank you, Timur. Thank you to all presenters. I think we'll now give floor back to the sixth session, right? Thank you very much, Gunta.
I will try to summarize our presentations. But before and it was dedicated to operational research completely. But before I go to the details, I think I feel like I need to touch a little bit the context. Because it describes the relevance of very well the relevance of operational research. In general, to achieve the ambitious goals to end TB, the countries need to eliminate the existing gaps in their respective TB programs, starting from case detection to successful treatment. But we all know that this situation has been severely affected by COVID-19 pandemic, and we discussed a lot about this. So I will not stop, but I just want to mention two things. In Tajikistan, a while ago, NTP, together with PAS Moldova, conducted a patient pathway analysis, and that indicated that during COVID-19 pandemic, the majority of TB patients delayed healthcare. They ended up quite late with more advanced diseases, which means they were spreading the disease in their communities for a longer period than they would have done so before the COVID pandemic. Besides, the NTP Tajikistan, together with the USAID, they conducted a modeling study to measure the possible impact of COVID-19 on TB incidence in the coming years. And as Dr. Asledin Rajabzoda mentioned yesterday, this study demonstrated that depending on the level of disruption, it could take anything between from 18 months to 5 years to recover TB program to the pre-pandemic level. It depends on the number of waves and the measures taken to control COVID-19. Now, all this happening when the countries had committed to very ambitious national targets, which were based on UNGA targets. The problem is also that now we are all lagging behind our targets, and we are even behind that where we were before the pandemic, which means we are desperate for better diagnosis and rapid, more patient-friendly and short treatment regimens. Approval of these new regimens that are coming in pipeline and are in development all depends very much on operational research. So I just really wanted to link this to the presentations today, because not all countries have the same capacity to conduct the operational research. Here's a good example, the first presentation about, which was presented by Dr. Jamshed from Uzbekistan about the SORT-TB training, SORT-TB structured operational research training, which started in 2019, and it's entirely dedicated to build the country's capacity on operational research. They had these sessions face-to-face in 2019, but because of the pandemic, they had to delay the third session and do it online. But it still didn't prevent them to actually publish 12 manuscripts out of 13 that were submitted to the International Journal of Environmental and Research and Public Health. And I think this is a very impressive achievement, but also it's a very good demonstration to other countries that there are resources to build the capacity to conduct more operational research. Also, in terms of support that countries need in tackling TB problems, but also conducting more operational research requires some external assistance. And I think the last presentation by Dr. Togdan Kalon was a very good example how much support, tailored support, can organizations, partners provide to NTPs. He described the ETICA support, and it's a very good example in to provide support in a sustainable way, because it's all technical and it's based on needs, and it leaves behind the technical knowledge. I will not go into details of the aspects of the support ETICA provides, but I just wanted to highlight that coordination efforts are very important to conduct the to support the NTPs. And then one of the important presentation by Dr. Erke Bulan was about ADSM. And I'm glad to hear that this is very well set up in Kazakhstan, and it's set up from like primary healthcare level up. And also, I'm sorry, I think I've
that was Bates.
Dr. Bates.
Bates was excellent. He is
Yes,
indeed coming
exactly.
from another side of our community farm committee, and having such a very well concerted interoperable cooperation between TB and farm regulatory agencies at the country level was an excellent example. Thank you indeed.
Exactly, exactly. And also it's important to know that this ADSM is completely backed up with the country's legislative framework. So it gets entire support from the country, from the government. And also is included in their national plan for 2021-2025. I think this is amazing. And then the two presentations actually were demonstrating the interim outcomes in the process of implementing MSTR treatment regimens in Kazakhstan and in Tajikistan. Both speakers described the process, and there are many similarities between these two presentations and two operational researches, but there are also some differences. Maybe differences based on the presentations, maybe that they're not just differences, but it didn't really come up through the presentation. One thing is that in Tajikistan, they include children below 6 on Delamanid-based regimen. So they have included small children in their operational research. I'm not sure if this is happening in Kazakhstan, actually. And the regiments, so there's the third regimen in Kazakhstan that includes pyrazinamide, which is not presented in Tajikistan. I think it'll be very interesting to wait for the outcomes of these two operational research. They have this main objective to assess the effectiveness and safety of the regimens, but there are lots of sub-objectives about the predictors of side effects and other issues, as well as follow-up 12 months post-treatment and defining the rates of the relapse. And I know this is what we discussed today, and there are lots of other operational research out there, so I just wanted to thank the presenters and also encourage the NTPs to take up and use all the resources existing to strengthen the operational research in their respective countries. I think I'll hand over to Kathy and Andrei now.
Yeah, thanks very much. A lovely summary. I don't have much to add, except I think it was a really excellent session, and I would encourage everybody to try to watch the recorded versions, because it really highlighted the added value of the operational research to help programs, for example, developing their diagnostic capacity, which was obvious was posing a problem during the operational research. So for the program, strengthening that was an advantage. And also even from Kazakhstan, the PV, the strengthening of that, they have now an electronic system, as I said previously today. it's incredible how far we've gone in the last few years, and it's excellent to see this region really powering ahead and using operational research as a tool to not only contribute to the evidence base on DRTB regimens, but also strengthen their own programs and capacities. So just well done to all the presenters. So I'll just hand over to Andre, who would like to just share something more about the European Research Initiative. Over to you, Andre.
Yes, indeed. Thank you very much. Please confirm you see my slides.
Yes, thank you.
Affirmative. And so I will not take a lot of your time. There will be only a 3 minutes interventions. And thank you once again for the host for letting me up doing this. And to thank also the USAID who supported us in the initiative for the regional platform, setting up the European Research Initiative, which is basically a catalyzer for introducing the new applications of an innovative one for the prevention and the treatment of tuberculosis. So back in 2017, the ERI has been set up here by the regional director of the WHO and being hosted by us here in the role of the secretariat itself. So currently the overall network contains about 350 members across the 50 countries of our region. The overall network defines the priority to operate in the framework of the operational research by a core group, which is an advisory body, independent one, that tells to the secretariat, to us, to the ERI secretariat, which activities needs to be prioritized. And of course, since the ERI has 3 objectives, which is identifying the priorities for the research in the region, which are basically a gap in the research knowledge, and those needs to be eliminated. The second one is build up the capacity, and you saw basically a presentation of applying the SORT-TB course, which has been initiated here at Euro at the country level. Jamshid did that presentation excellently. We do believe that so-called alumni, the European alumni, European SORT-TB alumni, are the future of our frontliners fighting against tuberculosis. They will take over the management at the national level and enlarge the capacity of applying the new innovation through the operational research mechanisms. And of course, under the third objective is the inter-country big studies, and it was several times mentioned in the framework of the conference, the MSTR and other studies. We did have also a study related to the identification of the barriers in TB and HIV collaborative activities. Soon we will launch a new inter-country study related to the preventive treatment of the MDR contacts, and so on and so on. And so here is basically the ERATB, European Research Agenda. You can find there 76 research priority questions. Take it and implement the research. If you need a mentorship, please don't hesitate to approach the ERI Secretariat, and we'll try to identify to you someone that will guide you through the process of the research implementation. And the last slide is basically the website. I would also like to advertise the cyber space, which we've established since the COVID put us down in our countries and restricted our face-to-face operations. So we've established a virtual workspace. I will soon put the link in there. There are already 120 participants there. Many of them are the moderators. You could raise your question there, and we will affiliate you to a respective moderator and a mentor that would help you to implement your research study. Thank you once again for the organizers and the host of of the conference. Much appreciations to Nana and to Katie for being with me and co-moderating the research session. Thank you very much indeed. It was Andrei Dadu streaming from Copenhagen. Over.
Дорогие участники, да, на этом мы завершаем обсуждение сессии 5 и 6.
Dear participants, this is the end of discussions for sessions 5 and 6, and now we are switching to the final stage of the conference. Summary and resolution.
Спасибо большое, Тимур, Андрей, за...
Thank you very much, Timur, Andrei, for excellent moderation of our last session. Yeah. Now, dear colleagues, we are coming to the final stage of our conference. So I would like to give the floor for presentation on the draft resolution of our conference to Dr. Trubnikov. Alexander, after you hear it, then we will send it to all the participants. So you could comment on this resolution. So if possible, please submit your comments by the 15th of October. And after that, the final version will be made available for everyone. Thank you for this opportunity. So resolution of the 5th International Conference on Integrated TB Control in Central Asia. We, the conference participants, referring to the resolution of previous International Conference on Integrated TB Control in Almaty in 2016, in Bishkek in 2017 in Dushanbe, and in 2018 in so referring to the political declaration of the UN high-level meeting against TB and the strategy till 2025, and recognizing the WHO strategy for TB elimination, which was approved at the 6th session of the World Health Assembly as a guiding document, shape the goals and objectives of the national TB control services in Central Asia countries. As part of reaching the objectives of the global TB strategy by 2030, and relying on the goals identified at the UN high-level meeting on TB for 2022, and the political declaration coordinated by all UN member countries, and having the new global USAID initiative, the global TB accelerator, and given sustainable health systems in the region, which currently are the key tool for countries to provide high-quality TB services for the population, but they are in need of further strengthening and improvement, and recognizing that along with visible progress towards decreased mortality and morbidity TB in the region, there are still multiple factors that prevent us from scaling up TB diagnosis and treatment, especially for the RTB and TB HIV. Given the impact of COVID-19, the deterioration of health system operations, namely TB programs, and negative effects on TB detection, and uninterrupted access to treatment, and greater stigma and discrimination, we would like to adopt the following resolution. We would like to confirm our determination to combat TB as envisaged by the TB control strategy and the key objectives of the high-level UN political declaration to combat TB till 2022. We would like to invest every effort to address the following objectives. First of all, to enhance political commitment in Central Asia countries to ensure TB control, and we will use multilateral approach to detect at least 90% of cases and to ensure treatment success for at least 90% of detected cases in the context of pandemic of COVID-19 and its effects on TB services. We will ensure access to services. Second, we will need to use the available financial resources as effective as possible and ensure a transition of countries towards self-sufficiency, and we will advocate for increasing the amount of programmatic and financial services for better quality of TB services, and after that, to ensure further development of TB services in the context of COVID-19 pandemic. We will ensure that TB programs respond to COVID-19 given the COVID-19 response plans. Ensure universal access to competent services to ensure early detection and treatment and dispensary observation for everyone, regardless of social, economic, and any other status if a person is affected by TB, including in the penitentiary system. And also, we will improve early detection and rapid diagnosis mechanisms at the level of primary health care. We will contribute to better quality for monitoring and treatment at the outpatient stage. We will ensure reliable cross-border control of TB among migrants, and we will finish the activity towards signing multilateral country-level memorandum to ensure interaction in this area. We will also consider additional opportunities to introduce new TB rapid diagnosis technology and consider additional opportunities to introduce innovative techniques to ensure patient care and the strengthening of TB services. We will improve access to rapid TB diagnosis, including TB with multiple drug resistance using new techniques. And we will enhance use of new drugs and shorter treatment regimens for all patients with drug-resistant TB, ensuring adequate pharmacovigilance. And also we will ensure availability of TB drugs of relevant quality, and we will promote implementation of the accelerated registration strategy, and then we will ensure adequate and timely diagnosis and treatment of pediatric TB, and special attention will be paid to measures against the spread of TB, both in health facilities and at the community level. We will recognize that the problem of TB HIV prevents us from reaching our original goals, and we will need to take urgent measures to provide TB HIV patients the services, patient-centered services. And we will contribute also to international research, engaging international agencies as partners, and we will disseminate adequate and reliable epidemiological data on TB, drug-resistant forms of TB, TB HIV in Central Asia countries. We will contribute to strengthening civil society and communities of TB patients, and we will implement and assess national TB programs in terms of reducing stigma and discrimination and ensuring early detection and treatment of TB. We will also engage a mechanism of social contracting as part of public funds, and other opportunities will be used so adequate financing could be provided to organize civil society efforts when providing psychosocial support, we could ensure active case detection. Then we will expand use of best practices with regards to engagement of civil society in anti-TB activities, focusing on vulnerable groups, including migrants and people in the penitentiary, given the human rights and gender aspects. So, and the last is to conduct the 6th International Conference on Integrated TB Control in Central Asia in 2022 in Nur-Sultan in Kazakhstan. Now, finally, we commit to implement this resolution immediately in coordination with all the partners and in cooperation with all stakeholder ministries, agencies, and the civil society. Thank you.
Спасибо большое, Александр.
Thank you
Thank you,
very
Alexander,
much,
for detailed
Alexander, for reading this resolution.
reading of the resolution. And as I mentioned, it will be distributed to all the
Kind reminder, we
participants.
will send this resolution to all the
And we'll be
participants, and
waiting for your
by
comments till October
15,
15.
we will be waiting for your comments. So
Now,
finally, I would like
to
to
give the
give the floor to
final
representative
remarks
of
to Leon Kupins, who is
WHO in
WHO
Uzbekistan,
representative in Uzbekistan.
Leon
Video
Kupins.
message. Уважаемые гости, коллеги, друзья,
Really like to thank you on behalf of the WHO for your attendance and your participation in the 5th International Conference on Integrated Tuberculosis Control in Central Asia. Thank you all for the speakers, for their contribution to a very successful program. And obviously an ongoing vote of thanks for the partners, for the Ministry of Health, for the national TB programs in the Central Asian countries, but also to the KfW, the USAID, and other partners. Only through partnership we can make the progress happen and we can make the changes we need to make. I've been told that the conference topics were very interesting. I myself could only attend a few online sessions, but those which I attended were extremely interesting. So again, a big thank you for all of that and all the comments and the questions which were raised by the audience. So colleagues, I hope you really enjoyed it, because I mean, when you are taken away from your day-to-day job, you are able to, in this conference, hopefully to learn a lot, to get the bigger picture, an overview of the bigger picture, what is happening in Central Asia, to learn from each other, to share ideas, and to come with innovative thoughts and ideas, of course, sharing results of research, sharing ongoing progress, sharing challenges, which we also need to hear and listen from, and then bring that all back to your daily job in your respective countries. And hopefully you learned a lot, you shared a lot, and you really enjoyed this international conference. So a big thank you again to everybody who contributed, but also those who were behind the scene, who made it happen. My own WHO team here, the speakers, the translators, all those people behind the scenes who we don't see, but contributed to the success of this conference. So, and we hope we are even getting a better and more interesting conference in 2022. Not saying that this one was not good enough, but we always hope for better and more technologies, more advanced technologies, ideas, research results, etc., etc. Wishing you all good luck in the future, and bring all this beautiful knowledge back to your respective countries in your daily work. Thank you and goodbye. See you next year.
Спасибо большое, госпоже
Thank you, Madam Leon Kupins, for kind words and for your wishes for the future. Dear colleagues, on behalf of the National TB Program, and in particular, Director of the Institute of Pulmonology Uzbekistan, Madame Perpiva Nargiza, who is currently couldn't participate personally, but kindly requested me to express great thanks to all the participants of this conference. On my behalf and my project and people who are involved in the preparation of this project, I would like to thank the Ministry of Health of Uzbekistan for this wonderful reception. And in spite the conference was remote, we felt very good support from the Ministry of Health. And we felt that the dialogue happened in spite the majority of moderators and speakers were outside of the region and in different parts of the world, including Australia, US, and all the continents of our planet. We also express thanks to the US Embassy, USAID,
миссии USAID в Узбекистане,
its mission in Uzbekistan, of course,
правительству Всемирной организации здравоохранения в Узбекистане, немецкому банку развития,
German Development Bank, Stop TB Partnership, and many, many others, thanks to whom this event has been organized. Thanks a lot to all the speakers and presenters, and thanks a lot to translators, as we had to catch up with the agenda and timing, and we have completed all the work in time. Dear colleagues, I also would like to remind you that although we're now closing our conference on Monday, we have the third day as a continuation of this conference, where we will be looking at Kyrgyzstan experience in reforming healthcare system, and especially public finance of healthcare sector, along with the TB services. This will be a virtual tour. So we have disseminated all the links, and we hope that you will be active, and this day will be interesting to you as well. All the presentations will be distributed, and you will also be able to continue to observe the live stream in YouTube. With this, dear colleagues, I would like to finalize our day, our 2 days conference. We still have the third day ahead of us. Wish you all success, health, well-being, and I truly hope that next year we will continue this meeting in physical exchange. Thanks a lot to everyone, and have a good day.